I'd like to officially begin this meeting, and I would like to start by asking Senator Cash to open us up in a word of prayer.
Heavenly Father, we thank you for this new day. We thank you for this opportunity to be gathered here together for this very critical day of testimony and hearing. Thank you for those who have taken time out of their busy schedules to come and appear before us. Bless us with wisdom, discernment, understanding, and all that we see and hear today. Pray, Lord, at the end of the conclusion of this hearing, that you give us all traveling mercies on our way home. In Christ's name, amen.
Gene, you have a word or two for us?
Mr. Chairman, I just wanted to offer a bit of explanation about the package that you have in front of you. You've got a file folder in front of you. It's got the agenda that was sent out. I'll just read this briefly. The Pandemic Preparedness Listening Session has invited to testify representatives of the Department of Health and Environmental Control, as well as individuals with medical backgrounds, those with relevant, credible, analytical input regarding the COVID-19 pandemic period. The aim of this hearing is to determine a framework for evaluating the public health response, identifying successes that should be replicated, as well as understanding areas of potential improvement if South Carolina must address another pandemic circumstance. That's the first document, Mr. Chairman. The second document is going to be the tentative agenda with each of the presenters listed on there. There is a third document in here. It's some code sections out of Title 4, and the reason we've included that is one of the presenters has referenced those. So in logical order, as the committee looks at those references, we thought it would be a good idea if they had the code language in front of them.
Sounds good. Thank you, Gene. Well, good morning. This day is finally here. I'd like to thank everyone for joining us for this post-pandemic preparedness listening session. Earlier this year, I approached Senator Burton, Chairman of the Medical Affairs Committee, to inquire about having this meeting. While we were in the midst of COVID in September of 2021, I sat on a similar committee chaired by Senator Martin. At that time, information was somewhat limited and the world was in chaos. 2 years later, COVID has been classified as endemic and our understanding of the matter has increased greatly. So now is a time of reflection. COVID-19, what happened? What did we get right? What did we get wrong? And how can we do better? My desire, as we hear from each of you today, is that we as a committee will have a clear direction on how we can improve in future situations. In my discussions with the chairman, I was made aware that the House of Representatives was contemplating a similar hearing. After meeting with my colleagues in the House, we decided that a joint committee would be in the best interest of the citizens of South Carolina. This committee is comprised of members from the Senate and House of Representatives, which I believe will be efficient and effective. The senators on the committee are, to my left, Senator Cash from Anderson, Senator Garrett from Greenwood. I'm from District 5. I represent Northern Greenville and Northern Spartanburg counties. Our partners in the House of Representatives are Representative Celeste Davis from Moncks Corner. She chairs the House 3N committee. She had an earlier obligation that's going to keep her tied up for just a few more minutes, and then she'll be joining us. Representative Long from Spartanburg, and Representative Alan Morgan from Greenville, who is en route. He had a little issue came up this morning that slightly delayed him. Our committee research director is Mr. Gene Hogan, and I often refer to him as Mr. Brilliant. To all the members of the committee, I want to express my greatest gratitude for being here and all the work that we have done and that we have before us. COVID-19 taught us a lot of things. It taught us that our world is not immune from a global health issue. It taught us that reactions based on fear can often be wrong. It taught us that reactions based on bad science can be harmful. And it taught me how quickly our freedoms and liberties can fall under attack if we allow it. Hopefully today we can learn from what happened and make better decisions should we be faced with a similar situation. Today we have solicited testimony from what I'll refer to as expert witnesses in the field. No one has been compelled to testify, and I look forward to hearing from each presenter. We have a full schedule today, and I'm anxious to get started. However, I would like to ask my colleagues on the committee if anyone has any opening remarks. If you'd like to do so, I'd be glad to entertain any opening remarks. Seeing none, I'll turn it over to Gene to get the presentation started. Gene, who's first?
Mr. Chairman, our order in front of us instructs us that our first speaker this morning will be Mr. Aaron Seary.
Thank you for being here, Mr. Seary.
Thank you for having me this morning.
We look forward to your presentation.
Thank you.
Mr. Seary, I did have one question. The committee here may have some questions for you about your presentation. Would it be your desire that we stop you along the way to ask questions, or would you prefer to wait to the end of your presentation and then ask questions? Either way is fine with us.
I'm happy to do it either way as well. If there's burning questions, I'm very happy to answer it.
Okay, thank you so much.
Great. Thank you, and good morning, and thank you for holding this. I think it's incredibly important. Now, there's obviously the pharmaceutical companies have billions of dollars every year to promote their product, and they're, COVID-19 vaccines, other vaccines are products. Car companies that sell cars want to promote their product, do a great job doing it, and the federal health authorities get billions of dollars of taxpayer money every year to also promote the products. And so having an opportunity to actually hear a bit about those who aren't in the business of promoting these products is a wonderful thing, and I commend you all for actually taking a whole day to do that, at least the portion of this presentation that I'll be presenting at. So I was asked to speak about COVID-19 vaccines specifically, and in particular, how could this system be so broken? So many folks are looking over the last few years at COVID-19 vaccines and have a hard time squaring what they understood about vaccines and then what they learned about COVID-19 vaccines. What do you mean it doesn't stop transmission? I thought vaccines stop transmission. Well, what do you mean we can't sue for injury? So forth and so on. And I think to understand COVID-19 vaccines, we need to understand how vaccines are treated in the United States. And I'm going to go through that in my presentation. I'll just start with who I am. I'm an attorney, and my firm has over 60 folks in it. About 40 of them do pretty much exclusively vaccine work. About 30 of them only vaccine work. We have I believe, the largest vaccine practice in the world that doesn't represent pharmaceutical companies. And including, we have a vaccine injury practice, about 10 folks, a vaccine exemption practice, and a vaccine policy practice. We did cases, for example, we got an injunction against the United States Air Force from kicking out over 10,000 members of the Air Force who the Air Force wanted to exclude because they filed for religious exemptions to COVID-19 vaccine that the Air Force just denying and wrote without actually honoring the First Amendment right to religious freedom. We got the FDA to produce the Pfizer documents they relied upon to license the COVID-19 vaccine that they wanted to make the public wait at least 75 years. Recently brought a lawsuit in Mississippi where we got a court there to restore the religious exemption for the first time since 1979. We were one of the firms that filed challenging the OSHA mandate up to the Supreme Court along with a bunch of others. I didn't get selected as one of the attorneys to argue, unfortunately. I wish it was. And we've done a whole host of other. We've got over 1,000 FOIA requests with FDA and CDC. We sue them regularly. They love us. We also do a whole host of other vaccine-related work. So, here's the critical thing you need to know about vaccines. Okay, and this is, I couldn't overstate this. All right. In the early 1980s, there were only 3 routine vaccines in the United States: DTP, MMR, and OPV, 2 injected, 1 oral. The amount of liability from the injuries those products were causing resulted in all the manufacturers go out of business or stop producing the vaccines except for 1 of each of those 3 vaccines. Instead of letting them make a better and safer product, and that's the vaccine schedule from the early 80s, it's right up there. There's 17 vaccines now on the schedule, multiple doses. instead of making them make a better product, a safer product, like we do with drugs, or airplanes, or cars, or every other consumer product out there, instead Congress passed, in its wisdom, the National Childhood Vaccine Injury Act of 1986. And what this did is it gave immunity, complete immunity effectively, to pharmaceutical companies for the injuries caused by their vaccine products. Not only for the 3 vaccines at that time, but for any childhood vaccine that they created henceforth. And that started effectively the gold rush, so to speak, where the schedule went from just those 3 routine shots to what you have today. There are 17 vaccines now on the childhood vaccine schedule, the CDC's. I'm gonna go back just one slide, and this is a U.S. Supreme Court decision at the top. It says the remaining manufacturer of DTP estimated that its potential total liability exceeded its annual sales by a factor of 200. That's the level of harm that was being caused by those products in the early 80s that resulted in this immunity. Okay, and to just really drive this home, there is no other consumer product that has this type of immunity. The product we say is safe, you can't sue the manufacturer for harm. It's disjointing at the least. Okay. What did that do? Okay. What it did was it eliminated the way we assure product safety in America. Period. The cars, every product around you for the most part is safer because companies don't want to lose money. They have an incentive when they make a product to make money. And if they think they'll lose money, they're not going to make it. It's what drives safety for most products. You can see there's another way you assure product safety, and I put it in very small letters on purpose. It's regulators. They have a job for sure. But in this instance, typically it's a far, far smaller role. Let's look at the impact. One example of the impact, a critical impact of giving immunity to pharmaceutical companies, okay? And that is an impact on clinical trials. It has disincentivized pharmaceutical companies from doing real proper safety trials on the front end, okay? Let me just, before I show you that for vaccines, before I show you that, I'm just gonna talk for a second about why clinical trials are so important. The reason they're so important is that after you license a product, it is considered unethical to do a placebo-controlled clinical trial, meaning comparing the experimental product with a group of people that get a placebo, an inert substance. That comparison, that statistical comparison, is the way that we evaluate product safety before it goes into the arms or the bodies of millions of Americans. That's how we do it. We do a clinical trial. So doing a clinical trial before you put a product in the market is so important. Here are the top 5 selling drugs from Pfizer of all time, according to some website. Okay. If you look at this list, 4 of these are drugs. 1 of them is a vaccine. The first 2 and the last 2 are drugs. In the clinical trial relied upon to license those drugs, they had a placebo control group. And look how long the safety review period was. Years. There's one that's different. Preparedness 13, right in the middle, PCB 13. That one only had 6 months of safety review, which, by the way, for a vaccine clinical trial is very long. And the control used was another vaccine, Preparedness 7. And Preparedness 7, as we'll see later, was licensed in a clinical trial, not against a placebo, but against another experimental vaccine. Let's compare that to childhood vaccines. These are the vaccines given in the first 6 months of life. Each of these are given 3 times, typically at 2, 4, and 6 months of age, except for Hep B, which is given on day 1, then 2 months, then 6 months. Look at the safety review periods, typically days or weeks, and none of them had a placebo control group, and that's true of virtually every single childhood vaccine. I'm not showing you this to create issues with childhood vaccines, but to help understand the paradigm into which COVID-19 vaccines fell into. People are outraged at the clinical trial of COVID-19 vaccines, but they have to understand what business as usual was for vaccines to understand the what happened with the COVID-19 vaccine. Those numbers might seem outrageous, so let me show you the FDA's website. So here's the vaccine schedule from the CDC website. The first one is the Hep B vaccine. Here's the package insert for the hepatitis B vaccine. If you open the package insert for every single product, you know this little piece of paper in every drug, and that big piece of paper you open, you go to section 6.1. Under the relevant regulation, clinical trial allowed upon to license that product needs to be summarized in section 6.1. If you look right here on the screen, you can see the section 6.1 of CombiVax HB, which is one of only 2 vaccines given to babies on the first day of life. And I'll read you the relevant language. In 3 clinical studies, 434 doses of a CombiVax HB, which by the way is a DNA vaccine, 5 micrograms were administered to 147 of the infants and children up to 10 years of age who were monitored for 5 days after each dose. That is what the FDA relied upon to license this product for babies before it was to millions of children in America. If I was going to come up with the most nefarious, crazy thing I could come up with to say about vaccines, I frankly would never have thought to say that because it does seem crazy, but there it is. This is on the FDA website. You can go there yourself. You see it right there at the top, you can see the FDA domain. You can pull up the package insert or go get one of the products and pull out the piece of paper. In fact, it seems so incredible. We FOIA the FDA on behalf of our client, the Informants in Action Network, and we have the actual clinical trial reports. I have a link for it over there as well. It's you can see right there, Hep B clinical trial reports. You can read the entire report yourself, submitted by Merck to the FDA to license this product. It's 5 days. In fact, you can even open the bottom link as well, which is a formal petition we have filed with the FDA on behalf of ICANN, saying, hey, your job is to only license products that are shown to be safe and effective in the clinical trial. I don't know what exactly the proper time period is for review. I can't tell you, what is the right number of children so it's properly powered. But 147 for 5 days? No, that definitely does not cut it. They had 6 months to respond to that petition. They have now well over a year and have not been able to provide a single shred of proof to substantiate that, in fact, this product was properly licensed, in our view.
Siri, what year was that rolled out?
It was licensed in the late 80s. Yes, it was the first recombinant Hep B vaccine. So I had the opportunity to depose the world's leading vaccinologist, Dr. Stanley Plotkin. On the left is the standard medical textbook on vaccines called Plotkin Vaccines. You can see that right there. It's a nice big book. You can read it. You can also use it as a weapon. It is that big. And in deposing Dr. Plotkin, I asked him about the clinical trial for this product. So you can hear from him. There's a little intro that tells you a little bit about him, and then you'll see me asking him questions about this product. And I try to bring home the point of how clinical trials are important and how important it is to do a proper clinical trial with licensure. I'll just play it.
It is my great honor to use the Stanley Plotkin Hall to open this meeting.
Our good friend and colleague, Dr. Stan Plotkin.
Dr. Plotkin, virtually every country in the world is affected by his vaccines.
He was involved in pivotal trials on anthrax, oral polio, rabies vaccine,
rubella vaccine, rotavirus vaccine, rabies.
He has earned the Distinguished Physician Award of the Pediatric Infectious Disease Society, the Finland Award of the National Foundation for Infectious Diseases, the Hillman Award of the American Society of Virology, the French Legion of Honor, and the Medal of Preventive Medicine.
He's a member of the Institute of Medicine and the French Academy of Medicine.
One of the very special things about him is the global impact that he's had, not just from the products, but from his book.
He developed a standard textbook for vaccines in 1988.
Bill Gates calls his book a Bible for vaccinologists.
I hope you all have indeed read the book.
I hope it's more accurate than the Bible.
He trained just a generation of scientists, including myself, to think like he thinks.
Dr. Plunkin, earlier you testified that there are two Hep B vaccines in the market, one by Glaxo, GSK, that's Engerix-B, and the other one is by Merck, Recombavax HB, right?
Yes.
This is the product, the manufacturer insert for Recombavax HB, correct?
Yes.
And the clinical trial experience would be found in section 6.1, correct? Correct?
Yes.
In section 6.1, when you look at the clinical trials that were done pre-licensure for Recombavax HB, how long does it say safety was monitored after each dose?
Let's see. 5 days.
Is 5 days long enough to detect an autoimmune issue that arises after 5 days?
No.
Is 5 days long enough to detect any neurological disorder that arose from the vaccine after 5 days?
No.
There is no control group, correct?
It does not mention any control group, no.
If you turn to section 6.2, under immune system disorders, does it say that there were reports of hypersensitive reactions, including anaphylactic reactions, bronchospasms, and urticaria having been reported within the first few hours after vaccination?
Yes.
There been reports of hypersensitivity syndrome?
Yes, that's what it states.
Reports of arthritis?
It is mentioned.
It also reports autoimmune diseases, including systemic lupus, erythematosus, lupus-like syndrome, vasculitis, and polyarteritis nodosa as well, correct?
Yes, that's what it states.
And also it states that under the nervous system disorders, it states that after that, there have been reports of Guillain-Barré syndrome, correct?
Yes.
As well as multiple sclerosis, exacerbation of multiple sclerosis, myelitis, including transverse myelitis, seizure, febrile seizure, peripheral neuropathy, including Bell's palsy, radiculopathy.
Radiculopathy.
Thank you very much. Muscle weakness, hyperphagia, and encephalitis, correct?
Correct.
These are events that are reported after vaccination, and as we just discussed, in order to establish whether it's causal between the vaccine and the condition, you need a randomized, placebo-controlled study. But that was not done for this Hep B vaccine before licensure, was it?
No.
Okay. And given that the vaccine now appears on the CDC's recommended list, isn't it true that it would now be considered unethical to conduct such a study today?
It would be, yes, it would be ethically difficult.
Chair, when it comes, so my question is, these negative consequences related to this vaccine, were these detected in the 5-day review, or is this something that came afterwards? Because I thought you said there was no control group, or
It was after.
yeah. So these 100.
That's in section 6.2.
Was this 147 or patient study, or is this some different one?
So the list that I read, that's in section 6.2 of the package insert, which is the post-marketing experience. And under the relevant federal regulations, I know folks think, oh yeah, they just list everything post-marketing, right, to protect themselves from liability. They don't have liability. They don't need to be so worried about listing everything. But the relevant regulations provide that they're only supposed to list adverse events that they detect after licensure that they believe they have some basically that's causally related. Not correlation, causally related. I could show you the relevant regulations in one of my later slides. But yes, that's not from the clinical trial. Those things I listed were post-licensure. With 147 children with no control and 5 days of safety review, you're not going to detect virtually anything. And it's not powered enough to.
Yeah, what I'm asking is, were these conditions that later appeared in the 147
No.
children?
No,
Or
sir.
is this just conditions that have later appeared in other people who have taken the vaccine?
Yes, sir.
Okay.
Going back to this chart, so just going back here for a second. When Pfizer does the clinical trial for the drugs it puts on the market, it wants to know what harms they cause before they go on the market, because it's liable for them. It wants to know the safety profile. So you have years of clinical trials that last years with a placebo control. Because if it goes on the market and it causes lots of harms, and those products are given often to, folks who are not well, so already a sick population, a narrow population. With vaccine, and they still want to know, but with vaccines that are given to healthy, typically babies, millions of them, typically routinely, they have the opposite incentive to their shareholders. If they know about a safety issue that prevents licensure, it's just, basic market forces. I'm not saying that's a nefarious thing, they're just doing what they're supposed to do as a company. And that's the way the market force has been set up. And you can see that play out in the clinical trials. Skipping forward, just looking at one more. So on that list, you might recall, Prepare 13 had a safety review period of 6 months. Well, the top box is the clinical trial, is part of section 6.1 from Prepare 13. And in that clinical trial that actually looked for 6 months, instead of a few days or weeks as they often do, it found that serious adverse events were reported following vaccination in infants and toddlers occurred in 8.2% among Prevnar 13 recipients and 7.2% amongst Prevnar recipients. So 8.2% of kids, healthy kids, within 6 months of getting Prevnar 13 had a serious adverse event. And I put the link up there, right there, you can look it up. To the FDA's definition of serious adverse event, it is something very, very serious. 7.2% of the Prevnar 7 recipients had a serious adverse event, healthy kids within 6 months. Since the rates were similar, from the standard perspective of FDA, that's safe. I mean, from the perspective of a parent, maybe not. From the perspective of the FDA license process, the rates are similar. So you might be saying, well, maybe they really knew that Prevnar 7 was safe because that was licensed based on placebo control. If you look at the box below, that is the link to the Prevnar 7 package insert. And Prevnar 7, as I noted earlier, it's right there on your screen, was licensed based on a clinical trial in which the control was literally another investigational product. It was, as you can see on your screen, an investigational meningococcal group C conjugate vaccine, not a placebo. I don't think they would have ever done that for a drug. Anybody, by the way, just go to Google, just type in FDA licensed vaccines, go to the FDA website, and you can go and look at all of this information right there. Last I checked, FDA is not an anti-vaxxer organization, so I think the information is reliable on their website. You can go take a look at everything I've just showed you. COVID-19 vaccine trials, by comparison, I know folks have taken lots of issues with COVID-19 vaccine clinical trials, but I'm telling you, if you look at the clinical trial for all childhood vaccines, you're going to make a decision on what vaccine to take based on this clinical trial, on how many people were in it. COVID-19 vaccines had 30 or 42,000, depending on whether it was Moderna or Pfizer. How long it reviewed safety, they did it for 6 months, and whether it had a placebo control. The Moderna and Pfizer COVID-19 vaccines had a placebo control for, on average, 2 months. You should take the COVID vaccine every day of the week over any other childhood vaccine. So when people look at the COVID-19 vaccine and they or take issue with the clinical trial, understand that from the perspective of the FDA and the perspective of pharmaceutical companies, they went way above and beyond. I know folks talk about how they were rushed, but I'm not really sure I'm not sure exactly what that means, because every vaccine took decades to develop technology, I mean, starting from when they invented the wheel way back when. All right, even mRNA technology took decades until they figured out how do we get it in, how do we deliver it. They came up with a banana model. How do we get the mRNA to stay integrated? They would create one of the, anyways, there's a whole process to it, and they were in the process of developing a COVID vaccine for the SARS-CoV-1 overnight, for sure. After licensure, they review safety, and every time they tell you when somebody complains of of an issue from a vaccine, they say rest assured, they don't cause it because we've studied it extensively. There are over 100 serious adverse events listed in the package inserts in section 6.2 of childhood vaccines and other vaccines. And I can tell you our firm, as I mentioned earlier, we've got 10 folks who handle vaccine injury claims. We do not sue pharmaceutical companies. Under the 1986 Act, we can bring a claim, but it's against the Secretary of the Department of Health and Human Services. We sue in something called the Vaccine Injury Compensation Program. It's part of the Federal Court of Claims in Washington, D.C., and the federal government is represented by the Department of Justice in those cases. We have no right to discovery. We can't take depositions. We can't get documents. We don't get an Article III judge. We get a special master. It's a highly constrained program and system. They paid out over $4 billion for damages, with a cap of $250 on pain and suffering, $250 for death. It is not your typical tort process, let's put it that way, okay? And it's supposed to be set up to make it easier to get compensation. I'm gonna tell you, it is not. Anyways, so we get calls day in, all the folks with various injuries from vaccines. We don't bring any cases for COVID vaccines. They also have PrEP immunity, which is another level. We can't even go to BICP for that. But for other vaccines, I can tell you that, what we do is when we get a call, my child had X issue after X vaccine, we start with clinical studies. Well, we don't do that anymore because they're pointless. So then we go to post-marketing literature, and I can tell you, it's pretty much vacuous for most vaccines. Again, if you're going to take a vaccine based on the studies that are done after licensure, you should take a COVID vaccine every day of the week. Let's use the injury that public health authorities have said they have most thoroughly, completely studied and assure you that vaccines don't cause that injury. Claim that vaccines don't cause autism, right? The claim that they tell you 100% they have studied it. So if they really haven't studied it properly, that will probably be a good reflection of the science, the state of the science, I would imagine, for the other 100 serious issues that people complain about from vaccines. Let's take a look at the autism one as the example, okay? I'm gonna play here's a quick video.
We're not sure of the scientific community what causes autism, but we know that vaccines do not.
Vaccines are really the one thing we have looked at as causing autism.
I agree with you. We know that vaccines don't cause autism. The science is clear.
Vaccines don't cause autism.
I do not deny in any way that we need to do more about autism, but it has nothing to do with vaccines.
Let me be clear, vaccines do not cause autism.
Vaccines don't cause autism. Absolutely sure. Absolutely sure.
Okay, so categorical, does not cause autism. Great. Despite despite the fact that health authorities tell parents with autistic children vaccines don't cause autism, studies surveying these families still showed that 40 to 70% still blame vaccines as a cause of their child's autism. When you ask them what vaccines they blame, the ones that are highlighted in red are the ones that they will list. And you can read those in those studies. I believe I have links to them in the last slide. No, I don't, but you can see the titles there. So when you look at this list, you can see hepatitis B, DTaP, HIV, PCV13, and IPV, all given in the first 6 months of life. And then at the very bottom there, you see the MMR vaccine, where the health authorities have focused all their efforts. That's given at 1 year of age. And so you would say, okay, that means they have studied all these vaccines to make sure they don't cause autism, right? If they're claiming vaccines don't cause autism, let's see if they've done that. And just to be clear, the claim that vaccines cause autism and the fact that their parents are claiming that all these vaccines can cause it is nothing new, and it certainly predates the claim that MMR vaccine caused autism, which started in the late 1990s with Andrew Wakefield. Folks, I believe, know about that, and that was in the late 90s. Well, this is the National Childhood Vaccine Injury Act of 1986. And in one of its sections, it identified the 11 most commonly claimed injuries from pertussis. pertussis vaccine, given at 2, 4, and 6 months, all the way back in the early 80s. And you can see that in that law, it said the Secretary of HHS shall complete a review of all relevant medical and scientific information on the nature, circumstances, and extent of the relationship, if any, between vaccines containing pertussis and the following illnesses and conditions, including autism. Okay, great. So, but here's the thing. When they commissioned the Institute of Medicine in 1991, they published the study that reviewed it. They found 0 studies. None. No studies that showed it doesn't cause autism, no studies showing it does cause autism. None. Right? Okay, so that's 1991. I'm not going to play this video because I don't want to run out of time, but this is the former head of the NIH, Dr. Healy, in 2008 saying, we haven't studied this question of vaccines and autism really. And she goes, I think the reason is they're afraid if they find an issue, people are going to be scared and not vaccinate her. So they don't want to, they're not studying it. Here is, again, the CDC, federal health authorities, another agency called HRSA, paid the Institute of Medicine again to review the 100 and something most commonly claimed injuries from vaccines. And on that list, again, was pertussis containing vaccines as well as diphtheria and tetanus, and whether or not it causes autism, okay? And here's the report from 2012. Their conclusion is the evidence is inadequate to accept or reject a causal relationship between diphtheria toxoid, and toxoid vaccines and autism. And when you read that full page, that's the entire thing. This was a giant panel, like, every specialist, Institute of Medicine got tons of our money, taxpayer money, to do this study. They couldn't find any. They found one study. They could find one study on pertussis containing tetanus, diphtheria, vaccines, and autism. It was done by the Geyer, and it actually found a correlation between autism and DTaP vaccine, given at 2, 4, and 6 months of age. But the IOM threw the study out. You know why? They said it's unreliable. They said, quote, it was from a passive surveillance system and lacked an unvaccinated comparison population. It was based on VAERS data. Are we familiar with VAERS? So they threw the one study they did find out, and they said there's no study. So here we are. 1991, there was nothing done. 2012, there was nothing done. I actually also asked Dr. Plotkin, who is the world's leading vaccinologist, about exactly this study and the question of whether or not you can claim vaccines don't cause autism if you don't know whether pertussis containing vaccines do not cause autism because you've never done the science on it.
This is an excerpt from the IOM's report, right?
Yes.
Can you read the causality conclusion with regard to whether DTaP and Tdap cause autism?
The evidence is inadequate to accept or reject a causal relationship between diphtheria toxoid, tetanus toxoid, or acellular pertussis containing vaccine and autism.
If you don't know whether DTaP or Tdap cause autism, shouldn't you wait until you do know, until you have the science to support it, to then say that vaccines do not cause autism?
Do I wait? No, I do not wait, because I have to take into account the health of the child.
And so for that reason, you're okay with telling the parent that DTaP, Tdap does not cause autism, even though the science isn't there yet to support that claim?
Absolutely.
That's 2018. So then on behalf of our client, we said, all right, maybe the world's leading vaccinologist doesn't have the proof. And you hear what he's saying. He's saying, look, I'm okay with saying it doesn't cause autism, even though I don't have a shred of evidence that pertussis-containing vaccine doesn't cause autism. So we FOIA'd the CDC, all right, the mechanism Congress gave us to check on those whose salaries are paid over the federal government. For all studies relied upon by the CDC to claim that DTaP vaccines do not cause autism. We gave them another chance, right? Come on, give us the studies. Here you go, give us another chance. Also give it to us, please, for Engerix-B, that's the Hep B vaccine, for Preparedness, for HIV, for IPV, as well as for whether the cumulative number of these vaccines do not cause autism. So we FOIA'd for this. The CDC stonewalled us, so eventually sued them in federal court. And eventually we entered into this final order, and entered by a federal judge. You can see it right there, signed by the Department of Justice on behalf of the CDC. I signed it on behalf of ICANN, and it was entered as an order of the court. And in this order, the CDC finally lists 20 studies that they say they rely upon to claim vaccines don't cause autism. Before this thing was signed by the Department of Justice and a draft was sent to me, I remember I spoke to the DOJ attorney. I said, hey, you just sent me a list of 20 studies. Did you want to put in the stipulated order? I read them. None of them involve the vaccines I'm asking you about. You really, the CDC wants to enter a stipulated order that's going to have a list of 20 studies, not one of which show a single study that any of the vaccines given the first 6 months of life do not cause autism, except for one, by the way. You know, they listed one of them was that 2012 IOM report I showed you about DTaP. That's the only one. Meaning, the only thing they cited in this list of 20 studies was a 2012 IOM report that looked for studies of whether pertussis vaccine caused autism, could only find one, and it had a correlation, and they threw it out. That's it. Well, you can see on the screen you signed it. 18 of those studies involved demersal, not an ingredient in any of those vaccines, or MMR. One involved antigen, and that study itself says you can't conclude whether it does or doesn't cause vaccines that cause autism, because it didn't study that, it studied antigen. And one involved MMR, demersal, and DTaP. That's the 2012 IOM report. Well, I'll show you one last video on this to just maybe drive home this point, okay? Because maybe the CDC can't find it. Maybe the Institute of Medicine can't find it. Maybe Dr. Plotkin. There was a lawsuit that specifically involved vaccines and autism, and Dr. Catherine Edwards, you see she's the third author of the standard medical textbook on vaccines. So she's one of the second, third leading vaccinologists in the world, probably. So she appeared as an expert in that case on vaccines and autism. So there's no there's no gotchas, lawyers. She came into that as an expert witness on vaccines and autism in a case where a child got a whole bevy of vaccines. So let's see what she had to say about the question of has the claim that vaccines do not cause autism, has that been properly studied? Again, it's just the example. I'm not saying vaccines cause autism. I'm trying to establish, are public health authorities doing the science they need to be able to say, yes, this doesn't cause myocarditis. Yes, this doesn't cause radiculopathy. It doesn't, transverse myelitis. Yeah, are they doing the work? I'm just using this as an example. Let's see what she has to say when asked about vaccines and autism.
According to your profile, you have done most of the critical trials relied upon to license many of the vaccines, correct, on the market?
Yes, sir.
Okay. So you're highly experienced conducting clinical trials, correct?
I'm highly experienced conducting clinical trials.
You're familiar with many of the clinical trials that relied upon to license many of the vaccines currently on the market, correct?
I am.
In your opinion, did the clinical trials relied upon to license the vaccines that Yates received, many of which are still on the market today, were they designed to rule out that the vaccine causes autism?
No. You badgered me into answering the question the way you want me to, but I think that, that's probably the answer.
Is that your accurate and truthful testimony?
Yes.
In the expert disclosures for this case, it asserts that, among other things, you will testify that, quote, the issue of whether vaccines cause autism has been thoroughly researched and rejected, end quote. It's your testimony that MMR vaccine cannot cause autism.
That's correct.
It's your testimony that Hep B vaccine cannot cause autism.
That's correct.
It's your testimony that IPOL cannot cause autism.
Yes.
It's your testimony that HIB vaccine cannot cause autism.
Yes.
Your testimony that varicella vaccine cannot cause autism.
Yes.
It's your testimony that Prevnar vaccine cannot cause autism.
Yes.
And it's your testimony that DTaP vaccine cannot cause autism.
Yes.
And you have a study that supports that DTaP doesn't cause autism?
I do not have a study that DTaP caused autism. So I don't have either.
Do you have any study, one way or another, of whether IPOL causes autism?
No, I do not, sir.
Do you have any study one way or another of whether NGRX B causes autism?
I do not have any evidence that it causes autism, nor that it does not.
And what about hib titer vaccine? Any evidence one way or another of whether it causes autism?
No.
And what about Prevnar vaccine? Any evidence one way or another?
No, sir. No, sir.
And how about varicella vaccine? Let me just finish. Are there any studies one way or another that support whether it does or doesn't cause autism?
Part of MMR, but not as varicella by itself, no, sir. No studies that say it does, or no studies that say it doesn't.
There have been studies that have found an association between hepatitis B vaccine and autism, correct?
Not studies that I feel are credible.
Okay, which study are you referring to when you say that?
Well, why don't you show me the study and then I'll see whether I agree with it.
You know, there's a popular conception about vaccine safety, and then there's a reality to that. There's what the PR machine says, and then there's what you learn when people are under oath and have to actually answer. And you just heard from the two world-leading vaccinologists, and you saw what the CDC was able to produce when held in federal court. On the issue, they say, on the claimed vaccine injury, they claim they have studied more thoroughly than any other vaccine injury claim in history. Just to put it into perspective, these are all the vaccines in the childhood schedule. The ones in yellow are the ones that have actually studied for autism. And then these are just some of the ingredients. This is the one ingredient they've actually studied. It'd be easy to actually study if you just compare it retrospectively. They have databases of insurance data, vaccine safety data link with thousands, tens of thousands of completely unvaccinated kids in it. It would be, in a few clicks, you could easily study this question properly by comparing with existing data retrospectively. Unvaccinated kids, vaccinated kids, but they won't do it. We've asked many times, including, and I'm going to skip forward. This is a family with triplets whose kids, all three of them.
Mr. Chairman.
Senator Cash.
Want to try to summarize a lot of what you've said, and you just tell me if I'm getting this correct. The health authorities that you presented here categorically state that vaccines do not cause autism, and yet when they're questioned under oath, they say clearly that there's no evidence one way or the other from the studies to indicate whether vaccines contribute to autism.
One qualifier on that, they don't say that there's no evidence from the studies. They're saying there are no studies. They haven't done them. Meaning I'm not standing here telling you vaccines cause autism. I am telling you they cannot claim they do not. You know, you want to make a claim, you need data. At least a peer-reviewed study. They don't have that. Last I checked, that's how science is done.
So the summary is there are no studies showing evidence one way or the other, except for one that they discount.
Well, the reality is there are actually a number of studies that do show correlation between autism and vaccines, including the hepatitis B study that I referenced there at the end that showed babies that got a hep B versus those that didn't have 3-time risk of autism. There's the DTaP study from Geyer and Geyer. There's a number of others. There's a Mawson study that actually did a homeschool survey of parents who were vaccinated versus unvaccinated. It did show 4 times risk of autism amongst the vaccinated versus the unvaccinated kids. But I'm not here to litigate autism. I was just trying to use it as an example of whether they properly studied safety concerns as a reflection of COVID injuries. You know, we have at our one group alone, React 19, and that is over 30,000 individuals seriously injured by COVID-19 vaccine. It's run by folks who, Brand Dressen, who's a former, was in the AstraZeneca clinical trial, and by Joe Wascott, who's a former orthopedic surgeon who, having the Moderna vaccine, can no longer operate because of what it's caused to his nervous system. And, they're banded together to try to help folks. The federal government, if these 30,000 seriously injured individuals in this one group are gonna get proper help, they need recognition that their injuries are from the vaccine, because until that happens, treatments are not actually just catered to the etiology of the disease. Insurance companies won't cover the treatments. Funding from NIH doesn't flow to find those types of treatments. It's critical that they recognize where the injuries come from if they're not. I'll give you an example of actually about that right now. I'll show you in fact the degree to which they will not recognize injuries. I'll give you, in our firm we have a whole intake process, and we've got an incredible number of folks who comes with COVID-19 vaccine injuries, and just to understand, people like, oh, well, those are folks who have issues with vaccines who call you about COVID, vaccine injuries. No, they're not. Folks who call us about vaccine injuries don't have issues people who have issues with vaccines don't call us for vaccine injuries because they don't take vaccines. People who call us for vaccine injuries are people who take vaccines. So these folks who took COVID vaccines, they didn't have an issue, that's why they took it. It's always funny to me when they call folks who claim vaccine injuries anti-vaxxers because they got the vaccine. Anyway, I bring up autism as a reflection of how science is not really properly done when it comes to claimed injuries from vaccines. With the COVID vaccine, they actually have done studies to agree that it's unprecedented from our vantage point as this works in the area of vaccines and the law, and that's to use science. I'm not an MD, I don't have a PhD, I don't get to just say things about vaccines in court or otherwise, I have to prove them. And so we have to look at the evidence. I can't draw on credentials, and that's what we have to do. So when you look at, let me actually, I think maybe also address your point in the following way. Federal law provides that the package inserts in section 6.2 should include, quote, only, and I have a CFR provision right there, those adverse events for which there is some basis to believe there's a causal, not correlation, causal relationship between the drug and the occurrence of the adverse event. So those injuries that you see listed, that we read before, Senator, from the hepatitis B package insert, that is the standard deployed to list the injuries, okay? Here is the section 6.2 of the Moderna vaccine. Just take a look at this list. It's got 3 things on it. It's got myocarditis and pericarditis, which will count as one, right? Inflammation of the heart or the heart lining. It's got anaphylaxis and immediate allergic reaction, or syncope, it's fainting. That's what it lists. That is all the pharma companies. So I hope that reflects to you the bar, the high bar, before they actually put something here. In our firm alone, for example, we have reports of individuals who feel like their skin's always on fire after COVID vaccine. Never had these reports from any other vaccine. So it appears there's an immunological reaction that's causing the nerve endings, which is not uncommon. I mean, look at Guillain-Barré syndrome, transverse myelitis, the accepted vaccine injuries that are neurological. There's a very direct correlation. There's a deep connection between the immune system and your nervous system. In any event, we have now a number of individuals who call our firm, one firm, with reports of this type of issue. There's no way that's random. A bunch of people didn't just come up with the fact that their entire body feels like it's burning all the time after a COVID vaccine and called our firm. But it's not here, and there are numerous other clearly distinct, unique injuries from COVID vaccines that are not on this list either. This is, by the way, the hepatitis B that we went through earlier. Look at this list. All right, this shot is given to a 1-day-old baby, 2 to 6 months old. And I think that over time, the COVID vaccine might have more as well. Okay.
Mr. Chairman. Question as well for just a moment.
Yes, sir.
I'm interested in solving problems. If there's an unethical position that physicians take that says that they can't go back and study it because clinician studies have already been done with it, it seems to me is that a federal rule among physicians or these folks that are doing this type of work?
So before a clinical study or a study will be done, there's something called Institutional Review Board approval, IRB approval, that every scientist will get. No scientists, including all the doctors in this room, if they go out and they do a study without IRB approval, they will be in big trouble. They can lose their license and go after them. I'm not aware of any IRB board that would approve a study of a vaccine using a placebo control where there's an already licensed product. But here's the problem with that, Senator. The problem is this. They never studied the first vaccine for every given disease in a placebo control. So, chickenpox vaccine, first one ever, right? So why not use placebo control? They did. They gave a very small group of people a shot of neomycin and antibiotics. Why would you do that? Or Prevnar 13, the very first vaccine, Prevnar 7, was licensed in a trial against another investigation vaccine, which is, again, something I couldn't make up if I was trying to make stuff up about vaccines. If you go across the board and you look at each one, I don't make the rules, I just know that that's what they are. But I agree with you, they should be done.
So in South Carolina, for instance, if our sovereign state of South Carolina decided we wanted to look into it, have our own studies done, you're telling me that the federal government says we can't do that?
It's not that the federal government says it can't do it, but the scientists who participate in it might suffer consequences professionally from the boards that give them their licensure and so forth. I'm sure that some of the folks in this room who are medical professionals can speak to that directly.
I
But
have to do that because it seems to me that what you've articulated, by the way, thank you for being an attorney who takes care of the people and trying to take care of this problem. Thank you for lawyers just like you to go out and study these issues and make sure we know what it is we should know. So thank you for being here. But I'm also looking for solutions. And it seems to me, to recap,
I've got
your solution is to do it right the first time and have clinical studies that really show the adverse effects. And then if we have those adverse effects, either, there's a percentage of people that might be affected, and it may be the only way you can do it. I understand it.
Well,
Since these doctors are saying that, well, it's okay if we lose 10%. Okay? If we save 90. So again, I mean, I understand the idea there.
Yeah.
But I'd like for the parent to know, especially in the children's situation, that there's a 10% chance your child's going to develop autism or whatever else.
Well, something on the order of 2% of children get zero vaccines in America, and according to CDC studies, they're very, they study these populations of people that are actually folks who are often PhDs. The more higher degrees and the more scientifically literate, less likely they are to vaccinate their children. I'm saying zero vaccines, not, they don't have access to medical care. I'm talking choosing not to. And so you have this existing population already. And so, for example, in the state of South Carolina, if you have any captive payer healthcare systems here, I don't know if you have a system in which not only does is the health insurance provided, but also the medical care. Within those captive payer environments, the data probably already exists to do the comparison. So you don't even need to go and reinvent the wheel. We've been trying to get access to that data. Obviously, if the state of South Carolina wants to force its release, it would be an incredible opportunity to do science. Let the data show what it shows, but let's just if you could, and it could be de-identified and released. We've tried every way. It's hard to see your way into de-identified data. I've tried.
Senator, when he mentioned that they may fall under, since they were South Carolinian residents, they may fall under some perplexity of a board or something, but I will tell you this, that the regulatory authority in South Carolina will do exactly what the General Assembly tells them to do.
I'm very happy to provide a list of suggestions after the hearing. I've got them.
Please turn.
Okay, I'm very happy to. Would you like me to continue? Okay. So just to wrap up the post-licensure safety, well, folks say, yeah, but the way that we can tell that the vaccines are making things better is that, we've got a healthier population. In 1986, there were 11 total doses of vaccines, and of DTP, MMR, and OPV, those three types of vaccines. So you got, a few doses of DTaP and so forth. The chronic illness rate, and we have citations right there to the CDC data, was 12.8%. 12.8% of kids had chronic health issue in the early 1980s. And we are now at 53 in 2017 doses. It's actually at 70. According to the 2011 study, about 50-something%. If you back out certain chronic health issues that may not be related to, that probably don't have an immune or a neurological or immune-mediated neurological basis to them, then you're maybe at something 40-something% of kids have a chronic health issue, not 54. And obviously, the explosion in these chronic health issues are often, they're immune issues, they're immune-mediated issues, and obviously at least the place we should start looking at is the product given over and over again to children to modify their immune system. I'm not saying that vaccines cause all these issues. I'm not saying that. I'm saying it should be studied. And then finally, you know, pharmaceutical companies have billions of dollars every year, and like a good company does, promote their product. Again, like car companies, like they use their money, deploy them in medical journals, associations, schools, public relations firms, news, advertising, lobbyists, so forth to promote their products. Okay, so you might be saying to yourself, fine, all right. Well, I get why the pharma companies do, but why would the federal regulators do this? Right? Why would they let a Hep B vaccine be licensed on 5 days of observation? It's hard to wrap your head around it, honestly. If it wasn't there in black and white, again, I wouldn't believe it if you told me. I had to FOIA for it, sue over it before I actually was like, all right, that's what it is. I'll run through this very quick because I think I'm getting close to the end of my hour. When Congress removed the market forces, I think it recognized that, and what it did instead is it made HHS responsible for vaccine safety. It literally transferred responsibility of vaccine safety from pharma to the Secretary of the Department of Health and Human Services, that's the Department of Federal Government, in which the CDC, NIH, FDA is located. And it's all, and that responsibility was is in something called the Mandate for Safer Childhood Vaccines. This is part of the 1986 Act, Section 27. If anybody wants to read it, 42 U.S.C.-3, 300 AA.1 through 34 is the entire act. It's pretty short. Any lawyers want to read it, should read it. Anyways, the Mandate for Safer Childhood Vaccines is basically what underpins the safety of vaccines in our entire country. It's got 3 little sections in it. Section A says make them safer in every possible way if you read the list. Section B says form a task force to make recommendations to the Secretary on how to make them safer, comprised of the head of the CDC, FDA, and NIH. And Section 3 says submit a biannual, Secretary of HHS, submit a biannual report to Congress on how you made them safer every 2 preceding years. Well, we said let's start with the easy stuff. On behalf of my client, ICANN, back in 2016 when I started doing this work in earnest, we FOIA for the task force recommendations. We actually go to federal court again. We always have to go to federal court apparently every time we want something. And there's only been one recommendation ever, one report, back in the 90s, and they disbanded the task force. So that's not been done. In terms of the biannual report for Section C, 0, never been done. We actually sued them in federal court. They finally agreed 5 years ago. They've never done the report. We actually recently went back and said, okay, like just a few months ago, it's been 5 years where you've committed, you've never done biannual reports. Have you now done them? They still have never done them. If they're not doing the easy part of the mandate for safer childhood vaccines, or just making recommendations and reports, think they're doing the hard part? Here's copies of the stipulated orders on all of those. Here's a report from Congress in the year 2000, and it was looking at conflicts in the vaccine approval and recommendation process. They looked at CDC and FDA committees. It's ACIP at the CDC side, it's back on the FDA side. And here's what the House report found, quote, the overwhelming majority of members, both voting members and consultants, have substantial ties to the pharmaceutical industry. By the year 2000, a lot of the vaccines and the tropical stuff that were already there. You think that they cleaned up their act. They didn't. 2009, the Inspector General again looked at it and found the same issues. And since we're here about COVID vaccines, the problem still persists. Dr. Edwards actually was one of the only 5 members of the independent data safety monitor board for the Pfizer COVID-19 vaccine. And I had an opportunity to ask her about that on the stand. I'll play that for you briefly. Is there a way to raise the volume? A little louder, if that's possible.
Pfizer to Pfizer?
Yes, sir, I have been in Pfizer. I've been working very, very closely with Pfizer, particularly with their COVID vaccines, and going at lots of reactions and adverse events. So yes, I have worked with Pfizer for assessment of vaccines.
You're part of the data safety monitoring board for the Pfizer COVID vaccine that was invented. You said that. You're one of the only 5 members of that data safety monitoring board who will provide the COVID-19 vaccine, right?
Yes, sir.
That's supposed to be an independent data safety monitoring board, correct?
It is an independent data safety.
That's a board that all of us in America are hoping on and relying upon in order to independently make sure that safety is properly assessed as the clinical trials for that virus is ongoing, correct?
That's true, and I can tell you that, very hard to those investors. They're very hard to do that and to be instructed.
Since it's supposed to be independent, it's critical that the members of that independent data safety monitoring board are in fact independent of the pharmaceutical company whose product is being evaluated, correct?
That's correct.
Isn't it true that directly before becoming a member of the independent data safety monitoring board applied to COVID-19 vaccine, you were an advisor to Pfizer?
Pfizer pays me to evaluate the safety of the vaccines because I'm a vaccine. So I do get paid to do the work that I was doing. Conscientiously.
The question was, before you became a member of the independent data safety monitoring board for Pfizer COVID-19 vaccine, isn't it true that you were separate before you held that independent position? You were an advisor to Pfizer.
Yes, sir, and I think what you're presuming is that because I've been an advisor makes me on their dome or makes me going to say what they want me to say. That is not, and has never been a part of my view. I say what I believe based on my expertise.
You don't think that financial incentives sway people's judgment at all?
It does not sway my judgment.
Why bother having an independent data safety monitoring board? Why doesn't Pfizer just have some of its employees on it?
Because we are independent.
Folks who were never advised.
We changed another definition of it.
So, I'm sure she believes it, that she can be impartial. I'm assuming she believes it. And that's part of the problem, though, is that the process is not independently done. Pharma companies have incredible influence. There's also a revolving door, as you can see. So, anyways, here's a quick example from the FDA's website to bring this a bit back to COVID-19 vaccines. This is the homepage of the FDA website. To me, this looks like an advertisement for the COVID-19 bivalent vaccine booster. As far as I'm aware, FDA is supposed to be deciding whether it's safe and effective. They're regulators. That vaccine is not even licensed. So they're promoting a product on their website, in my opinion. I see it as an ad. That they haven't even licensed yet. They haven't even assessed whether to decide whether it's safe and effective. Here's Dr. Peter Marks, the head of the vaccine division, head of the biologics division at the FDA, sits right below the head of the FDA. He's the guy who's really deciding about whether COVID-19 vaccines are licensed or not. He was making videos promoting the bivalent booster before it was licensed, telling everybody to get it. Do you think after telling millions of Americans to inject this into themselves and their children, when he's actually sitting in his office and now deciding whether or not it's safe and effective licensed, he's got to go, okay, safe and effective, or do I tell the public, oops, when I told them all to get it? It creates a conflict. I'll just leave it at that. And obviously, if the FDA was, interested in transparency, we wouldn't have to sue them to release the documents. They spent 108 days reviewing to license the Pfizer COVID-19 vaccine, which they wanted to wait at least 75 years to release to the public. Why is HHS abandoned safety? They're responsible for promoting vaccines statutorily, and they take that obligation very seriously. They're responsible for defending vaccines against claims of harm. We talk about vaccine court, and there's a revolving door between them and industry. Remember that mandate for safer childhood vaccines? You're you guys make laws, you'll appreciate this. When you look at the FDA's regulations for drugs, safe and effective, probably fill this room. You know how many regulations FDA has passed on that section of law on making vaccines safer than mandate for safe child vaccines? 0. There's no reg. There's no CFR provision. There's only that USC provision. It just sits all alone. It's crying for some attention. Hopefully one day somebody will give it some. Okay, so guarantee market plus no liability plus conflicted regulators. You go from this in 1986. This is the current vaccine schedule, childhood vaccine schedule. There's also an adult schedule. I left that off this. And just I interlace them here so you can get a look at it. Okay, that brings us to COVID-19 vaccines. I'll do this super quick because I'm pretty much out of time. So not only does the 86 Act immunity apply to the COVID-19 vaccine, so does the PrEP Act immunity, and I believe everybody here is familiar with that already, but I'm happy to talk more about that if anybody would like. And our federal government, by the way, we've got copies of the contracts that the federal government signed to get the Pfizer and Moderna COVID-19 vaccines. They were signed well before the vaccines were developed, and that's a contractual provision. They guaranteed Moderna and Pfizer PrEP Act immunity. Pfizer and Moderna knew with 100% certainty before they ever made a single COVID-19 vaccine that they would never be held liable for any injuries. It's right there on your screen. You can see the link. I compiled them all in that link below, and you can read the contracts yourself. That same provision is in all of them. What are the consequences? We went through some of that already. Looking at that, this is a young lady named Maddie Gary. She's one of only 1,131 children that participated in the Pfizer vaccine trial of 12 to 15-year-olds. That's her in a TikTok video before she got the vaccine, and she's now in a wheelchair and has a feeding tube. The fact that the Pfizer COVID-19 vaccine caused a serious injury is drugs do that. It happens. The problem is what Pfizer told the FDA when it submitted the clinical trial data to it about what actually happened to her. Pfizer reported to the FDA, and I'm happy to submit all of this, by the way, in a packet to all of you. Pfizer told the FDA that it was a functional abdominal pain, a she had a bellyache. We sent Dr. Peter Marks, who was doing the wait a minute videos, okay? We sent him all the medical records, everything, straight to the ER right after the first shot, documents, Pfizer, the vaccine. She's, ER hospitalizations. Like I said, our firm does COVID-19 vaccine injuries. This is very clearly, there's no differential diagnosis. There's nothing else that would explain it. She was totally healthy. She got the shot. Her neurological issues are consistent with what other vaccines actually can cause sometimes, which, like I said, trench myelitis type of events, CIDPs type of stuff. And so, but that's not what the Pfizer told the FDA, because Pfizer doesn't do the trials, obviously. Excuse me, FDA doesn't do the trial, Pfizer does. Pfizer just submits the data to the FDA. So when we finally submitted that information to the FDA, we have now actually, we FOIA'd for all of the internal communications at the FDA to see what did they do with what we sent them. We had to go to federal court in Ohio, Southern Ohio. We now have the internal documents in which Dr. Peter Marks emails Pfizer and there's communications, and Dan Woodcock, who was then the head of the FDA, says to Dr. Marks, what's with this young lady? And so, if I'm Dr. Marks, my reaction should be, Pfizer, what the heck? You told us functional abdominal pain. Instead, he says to his minions, go ask Pfizer what's going on. So they do send back this long, detailed report about her. Finally, right? So now they have it. And in the report, I remember the first time I read it, I go, oh, they're admitting she was injured by the vaccine. But then at the very end, you get to the Pfizer paid investigator at the trial site, and he says he does not feel it's literally the word, feel, I'll provide this all to you, feel that it was caused with the vaccine, and Dr. Mark sends it back to Janet Woodcock, the head of the FDA, and says, see, we're good. That was it. That was the entire, essentially, exchange as far as we can see from all the internal emails. That is how they treated a serious adverse event in the COVID-19 vaccine clinical trial. I mean, it should have been outrage. Somebody, should have gotten in real trouble for this. At the least, you should have reviewed all of it. Obviously, this just happens to be one person that came to us. I don't know how many other people are like this in the trial. I just happen to know this one anecdotal, this one issue. And again, the real issue is not that she got hurt, is a tragedy. The drug products can hurt people. It happens. It's the fact that there was a misreporting of the FDA, and the FDA didn't care. They were effectively misled, I'll put it that way. The other part is that the whole point of a clinical trial is to do statistical comparison. You don't know how the product reacts in the body, so right? You have a group that gets it, a group that doesn't, you statistically compare. You don't inject personal opinion, you don't inject the bias of the pharma company doing the trial. Well, this is the FDA's actual report. You can see the link right down there. Anybody here can open it themselves, and this is a quote from it. You can see 21 people died in the Comirnaty, meaning the Pfizer COVID-19 vaccine group, and 17 died in the placebo group. Wait a second, I thought the idea of this vaccine was supposed to reduce deaths, right? Isn't that the whole, so you have more deaths in those who got it versus the placebo group. That should be a problem. But instead what they did was, Pfizer went through every single death and explained, by the way, there were twice as many deaths from cardiac issues in the vaccine group than the placebo group. They don't really discuss that. But they go through every single death, and they explain it away. And FDA accepts that, right? But for example, when they did the efficacy analysis, does it reduce symptoms? That they accepted as statistical comparison, even though there were hundreds of people in the Pfizer trial who never tested who had symptoms. In any event, the point is this. When the data didn't show what they wanted on the deaths, they let them do an individual assessment, inject their opinion. They didn't do what they're supposed to do, which is just a straight statistical comparison. In fact, we sent a letter to the FDA and we said, hey, quote, why are the death data from the randomized control trial treated like a clinical case series rather than a RCT when it comes to assessing causality? Right? We said that to them. Well, why are you doing this? You should be doing statistical comparison. So they wrote back, here's the FDA's response. We're unable to respond substantively at this time due to resource constraints and the ongoing pandemic response. It's literally what the FDA told us. On the most critical question, why are you, anyway, it speaks for itself. The CDC did something, they had predetermined how they were going to review VAERS data. They were going to do something called proportional reporting ratio analysis. They published it. Anything over a 2 was supposed to be considered concerning. You can see here the list. We only have this because of FOIA again. This had to be clawed out of the CDC. Cerebral thrombosis, all of these issues well above a 2. Because what they do is they look at the historical baseline to the current baseline, and they come up with this ratio. But when the PRR numbers were off the charts, so we asked the CDC, we said, this was your own methodology, predetermined, when truth was original to you. And when it showed these really concerning numbers, aren't you concerned? They said, no. We decided to go with empirical Bayesian analysis conducted by the FDA, and that showed there's no problem. We said, great, can we have the empirical Bayesian analysis? They said, no. We're reporting to DC right now, suing, we're still waiting to get the empirical Bayesian analysis data. They said, sure, there's not an issue. That's the CDC. The other thing the CDC did is something called VSafe. This is what they rolled out in December 2020 with the very first vaccine. VAERS was the premier vaccine safety system, and they decided to roll something new called VSafe. Over 10 million Americans signed up for it. It was designed so that when you came in and got a COVID vaccine, you could sign up for this. Every day did a check-in for a week, and then every week for 6 weeks, and then 3 more times after that. The VSafe collected data from these 10 million folks. Most of the folks signed up for VSafe were between December 2020 and the first 2 months after that. These were the people who were enthusiastic, ran out to get the vaccine. These weren't the folks who were mandated, compelled. And it's not like VAERS. VAERS is there when you have an issue, you report. VSafe is just meant as like a social duty. You sign up and you submit information to it, okay? VSafe collected basically 2 types of data, check the box data and fill in the blank data. The check the box data falls into 2 categories of these 10 million folks. One is for 1 week they collected a list of reactions. All reactions that CDC say is normal.
arm pain, stuff like that. So that category was useless. It almost 60, 70, 80% of people reported having them, and the CDC said, that's great, that's reactogenicity, that shows the vaccine works. What was the point of collecting that data? I have no idea, because it's pointless. The second category that maybe, because it's called V-Safe, so assuming it's supposed to assess safety, is it collected whether or not people sought hospitalization, whether they needed medical care, that's one, missed school or work, or three, couldn't perform normal daily activities. Within the medical, healthcare, they also asked whether you were hospitalized, emergency room, urgent care, or telehealth. Presumably, that is where they were going to assess safety. It's called V-Safe, right? And there was a fill in the blank field as well, but that's for another day because we don't have that data yet, or don't have it. They won't give it, and that's going to be. I think there's another organization that's fighting to get it at the moment. With that said, so this was the list, like I told you. Symptom checks, chills, headache. It's too bad they didn't ask about, like, I don't know, how about like chest pains from myocarditis, pericarditis, or at least add it later. You know, this is who's currently the head of vaccine safety office at CDC said it's V-Safe just not designed to directly monitor specific adverse events outside of reactogenetic AEs, and they even admit it. Here's the thing. In October 2020, this was a presentation provided by the CDC to ACIP. Look at the issues that they list as adverse events of special interest from the COVID-19 vaccine. It includes transverse myelitis, encephalitis, all the issues that actually we're seeing from the COVID-19 vaccine. They're right there on the list. Myocarditis, pericarditis, stroke. It's all right here, well before the vaccine came out. They had an indication that it could cause these serious issues. Did they include that on the list of check-the-box symptoms of V-Safe? No. Why? Here is the protocol for V-Safe from November of 2020 before it was rolled out. This is from the V-Safe actual protocol. Again, every slide has a link at the bottom. You can go see the original document, okay? It doesn't link to the FDA because we had to get a copy of it, but this is the FDA the CDC document. These are the adverse events of special interest, pre-specified medical conditions. This is in the document designing V-Safe, sorry. It includes, again, myocarditis, pericarditis, but again, they were not checked the box. Instead, the medical care. Here's the part where they do health impact I talked about. Here is over 40 studies that the CDC published saying that COVID vaccines are safe, and what they rely upon, they relied upon VAERS data and V-Safe data. But they only included 1 week, the first week of people reporting healthcare after the data from the first week after getting the shot. And that still was like 2%, 1%, still concerning, I don't know why. When we finally got the check-the-box data, what we found was 7.7% reported needing medical care after a COVID-19 vaccine, 4.2% in the first 6 weeks after getting the shot. These are folks who, that is an incredible number. They say the whole point of the vaccine is to keep people out of the hospital. 70% of these folks who reported needing medical care were hospitalized, emergency room, or urgent care, and on average 2 to 3 times they went back for that medical care treatment. This is the CDC's own data. This data is from 10 million Americans, so it's far bigger than the clinical trial number, and it's not filtered through the pharma companies. It's probably the best indication you're going to get of what the real adverse event rate from this vaccine is, because it was done on large numbers without filtering. Okay, and then you can take a look at this. It shows an increasing, this is just the percent seeking medical care. This is not cumulative from the Pfizer COVID-19 vaccine, 3 years and older, and you can kind of see how there's an increasing number of folks seeking medical care. A last point is that, you know, this part I have to point it out, is that regulators acted surprised that the COVID-19 vaccines don't prevent transmission. But, you know, I found it comical that they did that because most vaccines don't prevent transmission that are required for school. I know the public doesn't know that, but it's the truth. I mean, here's the FDA doing a study on pertussis vaccine. Here's a consensus paper on pertussis vaccine. Pertussis vaccine cannot avoid infection transmission. Pertussis vaccine do not prevent colonization. They do not reduce circulation of bordetella pertussis and exert no herd immunity effect. Here's what we FOIA, we petition. I'll just skip over all that. I'll skip over all that. Diphtheria vaccine, same thing. Here's a CDC study saying it doesn't prevent transmission. Tetanus is not communicable from person to person. Polio, the polio vaccine we've been using for over 2 decades in America. I'll just read first what the CDC says on its website. Inactivated poliovirus vaccine protects people against all 3 types of poliovirus. IPV does not contain live virus, cannot cause disease. It protects people from polio disease, but does not stop transmission of the virus. polio proliferates in the intestinal tract, it's fecal to oral contamination. If you want to prevent transmission, you need immunity in your mucosal surfaces. Okay, IgA antibodies, the vaccine is injected into it only gives you IgG antibodies in your bloodstream, what they call systemic immunity. So it doesn't do anything to prevent transmission. I'm not saying this, okay, the CDC is saying it. It's right there on your screen with a link, you can go to it, and here's the world. And so, even the polio vaccine, it doesn't prevent transmission. This should have been no surprise. The meningococcal vaccine doesn't either. This actually comprises a lot of the vaccines required. This is the majority of the vaccines required for school in South Carolina. So, in any event, they could have, by the way, easily tested whether COVID-19 vaccine prevents transmission with 30,000 people in the clinical trial. They should have just given everybody a COVID test once a week in the trial. But, they didn't have enough. Obviously, millions of Americans were all given free tests, and everybody was asked to test all day long, including to keep their jobs, go to school. But apparently, they couldn't find enough tests to just test the folks in the trial once a week. Instead, they only tested you sometimes if you had symptoms. That's it. And that is what they used to determine that 95% number. Remember the 8 versus 100, even though hundreds more had symptoms ever tested in any event. Thank you very much. I'm happy to take any questions. Oh wait, I can go to the conclusion quickly if you would like. But basically, I was just gonna say, I'll just add that, mandates, the thing about mandates is you only really need them when there is questions about safety and efficacy. You don't need to mandate you to take products such as food or water and so forth. It's when there's a question of the safety and efficacy of the product really that it's been the tool of those in authority to you can't persuade you on the merits. They have to bully you, coerce you, and so forth to do something, especially when it's done from a place of somebody else's interest and those are dictating, those are forcing it, don't really fully understand it. I think it's just rather important that we, at the end of the day, I don't know if you're going to fix all these issues at the end of the day with, collective regulators. Are you going to make the trial better? Are you going to get rid of the immunity at the federal government level? Are you going to make post-licensure safety happen? Fixing these problems is incredible. The last stop in that entire train of problems that we've just gone through, in my mind, comes down to individual and civil rights. That at the end of the day, everybody always has to have the right to choose, and that means that they can't have their job, school, everything in their life, civil liberties on the chopping block if they don't conform. Because if there's folks out there who love every vaccine and every mask, and great, get every vaccine out there, wear 16 masks, live in your basement forever, because that's freedom, that's America, you should be free to do that. But if the day comes there's a medical product that you don't want, and you refuse it, and you can't get a job, and you can't go to school, and you can't go on a plane, then you don't have any rights. Then you're home alone, and you practice all your rights by yourself. Thank you.
I thoroughly agree with you, Aaron. I appreciate it. That's why I come straight out of the gate with a Senate bill to prevent the mandate. That was an extremely well-presented testimony. Does anybody have any questions for Aaron? You were pretty thorough, and we appreciate it very much.
I've got about 5 more hours, by the way.
In all honesty, you have presented a similar testimony to other legislators, and I've watched them on YouTube. So this was not my first viewing, but it was good to have you here in person. And the more we hear, the better we appreciate what you do.
Thank you. And if there's any follow-up information, evidence, documents, support that anybody would like, our office is very happy to provide it. Thank you for the opportunity.
Thank you, Aaron, so much.
Mr. Chairman, if I may, for any follow-up information that the presenters are going to send to us, to expedite that, just reply to the email that I've sent you in the past, or you can go to the committee mailbox, send it to the Medical Affairs Committee mailbox, either one of those, and get that to staff, and then we can distribute it quickly to the members you see up here today. Mr. Chairman, our next speaker on our agenda this morning is Jennifer Black.
Jennifer, come on up. Thank you for being here today.
If you look at your agenda, I'm probably the only person who doesn't have an ESQ or an ND or a BC or any of that. But I'm here because I have been following DHEC in the matter of public health since I stepped in as Dr. So I would say that I'm somewhat of an expert at policy with regard to DHEC, specifically for vaccines and individual rights. as you heard from Aaron, Siri, the framework that the vaccine safety exists under, it lacks the mechanisms necessary to protect citizens from harm. Without liability, manufacturers are not motivated to make vaccines safe, and when it comes to the oversight rule of HHS, their ability to objectively scrutinize safety goes away when they are not only appointed to the very injury that can be caused by the product they are charged to oversee. And I want that to be very clear. Why would you produce, when you denied claims, $4.2 billion has been paid out since 1986, but why would you produce a study that says all those denied claims since 1986 actually are valid? That would not be acceptable. So the reason why I wanted to bring Aaron was to lay that foundation is that there is a segue to South Carolina, because as you're here, and the response is that our health agency accepted without review the federal government's position on masks, on the vaccines, and on quarantines. And as you'll hear in future testimony, I want to keep something in mind. Even though our Department of Health is now under our governor, thank God, our public health agency still has an amazing expansive power under Title 44. Up until 2020, DHEC was generally sight unseen to realize that everyday people and relatively seamless in the processes related to things like exemptions, for instance. However, I've witnessed a shift in that time. And I have lived here, having followed DHEC since the moment I stepped in on the face of that. Anywhere from little changes like little red tape, with exercising religious exemptions, removing ability to opt out of the vaccine registry that is now required in South Carolina. Also, just before the pandemic, it was interesting, DHEC arbitrarily added a vaccine to the childhood schedule that was 12 years had been approved on the childhood schedule by the American Council for Immunization Practices. 12 years. So 2020, they added the Hep A vaccine to the childhood schedule. There was no outbreak among kids. There was an outbreak, but it was among drug users, homelessness, and men having sex with other men. So what I found was interesting was that, it was first thought and confirmed by DHEC. I called them specifically, and I have sat down with the attorney, chief counsel there. They could not add a new vaccine to the system without legislative approval. I think probably, well, I feel like you guys have been here when the HPV vaccine that did not happen, but that was under the premise that it requires a new vaccine to the childhood schedule, requires. So, 2020, I was really surprised that the Hep A was added without any type of regulatory change, nothing, no legislative approval. So I was informed that the new DHEC had interpreted the regulatory authority to be able to add it. What had changed with policy? Every inch of what had been given them under Title IV. This is a very scary thought that they can just add the vaccine. So here's my point. I said the fact that remains that what becomes policy really is dependent on who is running the agency. And under the backdrop of the falsehood of pursuit of vaccine safety, as you heard, liability free vaccine industry, and unchecked executive orders on the federal level, South Carolinians are vulnerable to any regulated pharmaceutical industry and elections or appointments, not by the needed limitation in the regulatory power that they currently have. And yes, while we did not experience the full breadth, I'll fully admit that, right? The regulatory power under the Title 44, there's some pretty scary stuff that's in there. We watched it play out where states have the same type of regulatory power. Their agencies have a regulatory power provided under tyrannical governors. And both our neighbors and our folks in the West. We really saw how that could play out. So my
Thank you, Jennifer, and I do want to give you kudos. You were the one that first sort of alerted me to Title 44. I mean, we as legislators, I don't have the code section memorized. Books and books and books, that's it. But once I was alerted, I was alarmed. And I do currently have a Senate bill that basically just guts a lot of Title 44. It needs to come out. I think that was done in the early 80s where there was some things going on, sort of pandemic style related, and there was a lot of knee-jerk reactions going on in legislatures all over the country. But it actually frightened me to see the power that DHEC could wield under Title 44, should any sort of state of emergency exist. And those powers strip the freedoms and liberties away from the people I serve. And that's wrong, and I'm not going to stop till we fix it. So thank you for that. Thank you for coming today. Thank you so much, Jennifer. Gene, who's next?
Mr. Chairman, our next presenter is Dr. Denise Hilty.
Thank you, Chairman Corbin and committee members for holding this very important hearing. Can you hear me okay?
Yes. I did have one question. Would you prefer we save our questions to the end, or can we ask as you go?
I would, whatever you're comfortable with.
Okay.
I'm adaptable.
Thank you.
Thank you for holding this hearing on this extremely important topic that has had far-reaching impact on our state. I think as a provider for over 20 years, identifying a problem so you can fix it is extremely important. So thank you very much. So just in our short time here today, I'm going to just, again, identify causes for loss of public trust in DHEC, identify the deleterious impacts from DHEC guidance on our state. I did have serious concerns in 2021 about data collection and also K through 12 guidance. So I did reach out to DHEC and have a dialogue with them about what their data criteria was for hospitalizations and deaths. I also submitted 4 FOIA responses. I alerted a DHEC board member to my concerns, which he shared. So he did reach out to Director Zimmer, and we've had 2 meetings to discuss exactly how these policy determinations were made and what corrective actions would be happening. I appreciate those conversations. However, I did submit a document to him with questions that I think would be helpful if they did respond in writing, explaining how these determinations were made and corrective actions. That would provide a lot of transparency to the legislature as well as South Carolinians, which could help build back public trust, and we could understand exactly why things went the way they did. And then most importantly, I'm going to give suggestions on how to rebuild trust and improve public health in South Carolina. So I just want to review public health structure so people have a clear understanding. We talked about the federal health agencies. So we have HHS on a public health recommendation level. We have the CDC. The CDC does not regulate, so they're a resource for the states. We do pay federal tax dollars that fund them, but ultimately they don't really have any regulatory power. The states can choose to adopt their guidance or not. Different states have statutory requirements. I did confirm with DHEC Legal that in South Carolina, DHEC is the sole advisor for all public health guidance. So again, it's good we have a resource for public health, but we are not required to adopt any CDC guidance based on their recommendations. So again, DHEC like CDC, doesn't really regulate. We heard about the school vaccination requirements. They do regulate there. But for many of the COVID protocols and other guidance recommendations, they do not. So the yellow down here, you can see elected officials, schools, providers, institutions, businesses, individuals. They can craft their own policy, they can adopt DHEC policy. And then there's the media that disseminates a lot of the information that DHEC does produce. I just want to provide an example because even though DHEC doesn't have regulatory power, they have great influence. So for example, DHEC gave a K through 12 masking presentation to the DHEC board in August of 2021. They did make a recommendation to mask our school children within a very short time period. It could have been a coincidence, but shortly after that, the Charleston County School Board did mandate masks in Charleston County. This was against the legislators' wishes since they put in the proviso to remove funding from any school that mandates masks. It was difficult. The Attorney General actually issued a statement. Molly Spearman at the time, who's the school superintendent, issued a statement advising against it, but they did it anyway based on that recommendation. Also, providers disseminate this information to their patients, treatments, vaccines, masking, whatever it may be. They really depend on DHEC, and they assume that rigorous vetting of the scientific literature is happening. Businesses, often, even if they don't agree with the guidance per se, they do have a legal vulnerability if they don't adopt DHEC state guidance or CDC guidance. So again, even though there isn't they can't really mandate much, they do carry heavy influence, so it's very important that they review the scientific literature and prioritize South Carolinians above CDC. So in my estimation, the main loss of public trust in DHEC was that DHEC adopted and encouraged certain CDC recommendations and talking points without extensive review. These were not supported by the body of evidence, which I'll review, were not adapted as emerging scientific evidence and new information became available, were not scientifically justified to be implemented in all age groups and populations, and had detrimental impacts, which resulted in other serious public health problems in our state. So some of those detrimental impacts include learning loss and developmental delays, an exponential increase in mental health disorders and suicidal ideation, especially among the young, substantial economic loss, and a false sense of security. This isn't spoken about a lot, but people really depend, especially those at risk, to follow these recommendations that are supposed to protect them. So if they're actually not proven benefits to protect, then that gives a false sense of security and can put these people in a vulnerable situation. The Hoover Institute, which is affiliated with Stanford, did an assessment of the states. A lot of people want to know how did South Carolina do compared to other states, because we know that pretty much the whole country suffered in different ways. The learning loss, we can see we're really behind in reading in South Carolina compared to the national average, and math we're a little bit ahead. Just returning schools to their pre-pandemic performance will not fix this. So these are expected to stay with us. This was a cohort in 2019 and a cohort in 2022, and they compared the two of 8th graders. Another finding in that assessment was 1.7% of GDP over the 21st century was lost in South Carolina, equaling about $129.5 billion. South Carolina students in the COVID cohort can expect on average a 5.1% lower lifetime earning. So that's significant, and that could be the difference between living in poverty and not living in poverty. 5% is a big number for a lot of people. So what is public health? Why are we here? Public health is the science of protecting and improving the health of people and their communities. This work is achieved by promoting healthy lifestyles, researching disease and injury prevention, and detecting, preventing, and responding to infectious disease. So like anything, if we're doing well, then we get good results. So that would equal a healthy population. Public health, we have a public health agency, but public health is much more than vaccines and masking. Okay, so there's there's nutrition, sleep, loving, connected relationships. And each population can be different on what their needs are. So having that thoughtful, targeted response typically almost always gets the best results. So in reviewing the first FOIA request response, just a suggestion to the legislature, you can investigate why DHEC staff did not accurately report COVID-19 hospitalizations and death data published on the DHEC website. So I did have a correspondence about pediatric COVID data, and they were very responsive, but at the end of the day, they did not divulge the data criteria. When I did submit a FOIA request, they gave me 17 PDFs of just COVID testing. So subsequently, it's indistinguishable whether the data on the website, hospitalizations were directly caused, contributed to, or were not related at all to COVID-19, like an accident or something else for a COVID positive person. So, you know, we all depend on accurate data. Health outcomes is extremely important when we're crafting public health policy. Transmission is important, but we're really looking at health outcomes at the end of the day, especially when we have seasonal viral illnesses. So basically, school board members, like I mentioned before with the K-12 masking, and others depend on this accurate data, so we can all assess individual risk and risk to specific populations, again, so they can craft appropriate and proportional public health policies. So this is the DHEC published COVID-19 deaths by age. We can see age 5 through 17, which is K through 12, there were 22 deaths. And it would be really useful for school board members, if they were even aware of this data, to know exactly were these healthy children enrolled in school, did they have serious illness or comorbidities, or were there some who died in accidents, et cetera. Okay, so to build back trust, obviously collect and report accurate data. Inaccurate data collection and reporting is unacceptable, and it has far-reaching impacts on our state. DHEC staff, I don't know if the legislator can do this, needs to be accountable.
Dr. Hill.
Yes.
Could you go back to that former slide?
Sure.
Okay, so that's the total, this is the DHEC published COVID-19 deaths by age.
Yes, and this has been removed from the website just because they're not tracking it anymore, publicly anyway. And hospitalizations were removed a while ago, like over a year ago, I think.
Okay, so if you add all of those up, the 12, the 8, the 14, 251 and on down,
yes,
that'll give you a total number of South Carolinians who passed away due to COVID. Now, is that confirmed that it was that they died from COVID and not just with COVID?
Yeah, so based on the responses I got, and I did have 2 meetings with Director Simmer about this. So based on the FOIA responses and my conversations, it's indistinguishable whether someone died with COVID. So it could be a contributing factor, for example, if you're sick in the hospital or you have chronic illness, and that would be the thing that ultimately led to your demise. Or if someone died of COVID-19 disease, meaning a direct cause of COVID, or if it was another factor like a motorcycle accident, acute appendicitis, and they just happened to test for COVID.
Right, yeah, that's what I was curious. If
Yeah.
you went in with an accident, crash victim, and they passed away, but then tested and had COVID, so they didn't pair that out, right?
So I also wanted to mention, I will provide all the correspondence that I've had with DHEC related to details of the data collection and the FOIA responses and the document that I'm hoping to get a written response from that I think would help everybody just provide some transparency. So you'll be able to read through that. And then
if you'll submit those to us, if DHEC won't answer you, I believe they'll be wise enough to answer us.
Great, thank you.
Send that to us, we'll get you some answers.
Thank you so much. So if DHEC staff can be accountable to provide transparency by posting on the DHEC website data criteria guidance documents on how data is collected and reported. Also, this just goes with my whole presentation, citing known knowledge gaps, sound scientific citations that support and justify all current and future public health recommendations, I think is extremely important. Often, I go down rabbit holes. I'm the one who clicks on the citations. When you click on a citation, when you read something, it should support the statement or the policy that they're issuing, and that just goes with anything, not just the DHEC website. So that would build back trust, and it would absolutely provide transparency. And we see many CDC links on the DHEC website, and then when you click on those, there's not a lot of citations there either. So that's not really a, again, DHEC is charged with being the sole advisor for public health, not the CDC. Okay, so the second FOIA response that could use investigating is why DHEC staff were unable to provide scientific evidence, including the risk-benefit analysis, or their recommendation of universal pediatric COVID-19 vaccination for age 6 months and up. DHEC staff, the DHEC FOIA response was, I don't know of any written risk versus benefit analysis developed by DHEC, and I can't even recall all of the data and studies and articles I read on the vaccines, their development, their trials in children, et cetera. So parents, citizens, we just assume that DHEC is independently, rigorously reviewing this evidence and not just adopting a CDC guidance. When we do risk-benefit analysis, this is from the European Journal of Epidemiology, published about a year ago, or a little over a year ago. It's well-curated global data. That is an infection death rate. So we can see for school-age children, for example, the infection death rate is 0.0027. So when people say statistically zero, that's what they're talking about. So that would be taken into account when you're recommending pediatric vaccination, for example. There is, I just wanted to mention, there is a debate in public health, an ethical debate, whether implementing policies that carry risk of harm in low-risk populations like children to protect the vulnerable is ethical or not. So sometimes when you hear this argument about pediatric, they say, well, it's to prevent transmission, but we know that didn't really play out the way we wanted it to. So that's the debate. So agreeing on facts and then having that ethical debate could be a useful conversation. So this is from the British Medical Journal, published in October 2020. So this is before the vaccine rollout. So Moderna, Pfizer, it's hard to see, I know. So basically, I think this was mentioned, the primary mortality, hospitalization, and viral transmission were not evaluated as primary endpoints in the study. So we just didn't know. Yet DHEC staff stated in a media article that I have the utmost confidence in safety and effectiveness of COVID-19 vaccines when obviously efficacy was not known in the real world, viral transmission was not tested, and of course we did not have safety data because it hadn't been released to the public yet. So yeah, so messaging should always be consistent with the body of evidence and what we know and what we don't know. This was an infographic taken from the DHEC website that was put up in December 16th to January 2022, showing vaccination status of cases, hospitalizations, and deaths. So we can see that about a little over 50% of those hospitalized were vaccinated, about 36% of the deaths were vaccinated. Again, the data is kind of messy, so we don't really know what this means, but the messaging that vaccines will save you, if you're vulnerable, and reduce hospitalization and death needs to be supported by current data. So making sure that we're collecting and reporting on that, and that is actually the truth, so people can make those complex vaccine decisions for themselves would be really important. So to build that trust, is obviously a thorough scientific review of the vaccine is urgently needed. We all depend on that, and some people can do it themselves. Like, I feel like I have a good handle on it, but the public in general may not have the educational background or to know even where to look or have the right questions. So we do depend on these public health agencies, even though technically, legally, they don't have direct reach over our lives, but they have a lot of influence. Passed legislation requiring a legislative oversight when adding vaccinations to the school schedule. Clearly, looking at public health necessity, things like that, is this needed? Reviewing safety, especially after this, we absolutely need oversight. And commence an employment review of appropriate DHEC staff to determine if minimum job requirements are being met. The third FOIA is why DHEC staff did not inquire about the nearly 9,000 COVID-19 vaccine adverse events South Carolinians experience reported to VAERS. Is that what VAERS is? The federal database, it's a passive database. I don't know if that was covered before. So the DHEC staff FOIA response is stated that DHEC does not follow up or investigate VAERS submissions. In fact, CDC doesn't provide us with the information on or communicate with us about entries related to South Carolina, and they or the FDA do all the investigating and analysis on these reports. So if we look at the number of VAERS reports in South Carolina historically, these are all the VAERS reports collectively, all the vaccines. From 2012, we can see an enormous uptick in reported events in 2021. Clearly, if we're recommending something, we want to make sure if there's an unintended negative consequence happening, especially when we know historically there is potential negative consequences with vaccinations and all medications. So 90, I printed it off for the chairman, and I will send you the link for this. 90 reported deaths have occurred. It does have a description. I also want to note this is public. So this took me a couple minutes to generate this report, and I can also generate a report and send you the 9,000 so you can read exactly the circumstances of these adverse events.
Dr. Hilton.
Yes.
If you would, this question has come to my mind a lot, and I've been asked, how hard is it to go online and navigate the VAERS system?
So the VAERS system, that's called the Wonder database, that is very difficult to navigate. However, there's MedAlerts database, so a data scientist basically captures the Wonder database information, and he created a much more easily navigatable system.
And that's called what now?
It's called MedAlerts,
MedAlerts.
and it's on the National Vaccine Information
But
Center's
that's not the
website.
that's not the one that everybody typically thinks of. Everybody kind of thinks of the VAERS system.
Exactly, yes.
And so is that, if you're vaccine injured, is that easy to go on and go into the system and report it, or is it a bit arduous to do?
So the reporting itself is difficult. Also, many people, even though when you get by the 1986 Act, you're supposed to get what's called a VIS that has that VAERS information on how to report. Anyone can report, it's passive, that's why the data isn't the best, because we don't know. Just because you report doesn't mean it was caused. It's for the government to curate and do a data analysis and see if there's any safety signals. But most people, aren't aware. HHS did a study, and less than 1% of vaccine adverse events are reported to VAERS. And then providers and the public have complained, for lack of a better statement, that it's very difficult. It also times out. So you have to put in all these fields, and then if it times out, you have to start over again.
And that was my point, because I've been approached by a lot of people who, I'll give you an example. A friend of mine was vaccinated and had some ringing in their ear. Another friend of mine vaccinated, had some ringing in their ear, lost their hearing. Now have to have a hearing aid. I don't think that was ever reported to VAERS. I don't think that was, and I would agree that what'd you say, 1 in 100 adverse events perhaps are reported, or 1 in 10, what do you
So based on one HH study, a Harvard Pilgrim study, it's less than 1%. And then there was another, I believe, CDC study that was between like 1 and 10%. So very low rate.
Right, so if the scientists can, proclaim that the vaccine is safe and effective, we can also proclaim that the VAERS is woefully underreported, right?
Yes, and I will say, so my next point here is when I did, so I have contacts at the CDC's Immunization Safety Office. They're the ones who run the VAERS database. If you call them up, they will agree that they know that vaccine adverse events are underreported. With the senior scientists there, this is not controversial at all. And when I did talk to them about South Carolina, and if they're communicating with the states on vaccine adverse events, they did say that they do communicate with South Carolina designated vaccine safety coordinators. They should be receiving weekly reports on specific South Carolinian COVID-19 adverse events from VAERS. So I don't know DHEC might not be in the loop on that, I'm not sure what's going on, but the people making those recommendations should absolutely be monitoring those adverse events. Whether they need to investigate them, that's a whole nother story, but they should be aware of that. Of course, South Carolinians depend on and expect DHEC to closely monitor the safety of COVID vaccines. I think most South Carolinians would feel very upset that this isn't being monitored. So to add complexity to this, based on DHEC's safe and effective messaging, many South Carolinians have been required to accept COVID-19 vaccines as a condition of their employer or educational institution. Also, DHEC staff who recommend universal COVID vaccination cannot be held legally or personally accountable because of the 1986 Act and the EUA at one time. I agree, passing legislation that protects South Carolinians from being mandated indemnified products that carry risk of harm. Again, we have no idea if this will ever get fixed, but protecting citizens. I've been a provider for years, mostly in New York City. I've worked in almost nearly every population you can dream of. I can tell you for sure, the overwhelming majority of people can make intelligent healthcare decisions for themselves. They don't need to be mandated anything. The final FOIA response that I believe needs to be investigated is why DHEC staff have not provided adequate scientific evidence, including a risk-benefit analysis to support the recommendation of universal masking in schools. Based on the FOIA response, DHEC staff reported the recommendations DHEC provided were based off CDC guidance. They did submit that DHEC board presentation that I spoke about in the beginning on K through 12 masking, and they did rely mainly on observational studies and models for efficacy, which are not reliable. They did do a review of safety of masking, and in the absence of evidence, concerns that universal masking in schools may have unintended harmful impacts on children were rejected. So this is a slide from their presentation. Basically, they state that no data on impact of mask wearing on academics were identified during a thorough review of the scientific literature. This kind of echoes what Mr. Siri was saying. So in the absence of evidence, it's not in the best interest of South Carolinians to presume safety. That's a big no-no, and if people knew that, then I think the messaging isn't consistent with the body of evidence.
Dr. Hilty, you showed a slide back or two of the children in school wearing the little surgical masks. Those were the ones that were handed out by the hundreds of thousands as you went into grocery stores or whatever. There's been studies done on the efficacy of that type mask. N95 works better than this, and people are wearing cloth masks, different sort of face coverings. Do you know off the top of your head what the efficacy is of the typical surgeon mask or the cloth mask? I mean,
so based on that, I'm going to cover that in a little bit, but based on the body of evidence, and I spoke to the director about this in both meetings, based on the body of evidence, using the highest quality of evidence, the body of evidence suggests that masks do not support a public health benefit and viral transmission and protecting people from viruses.
and I saw a study on that sometime back, and I forget the numbers, it was some months back, about how effective the N95 is. Evidently the best. If it's properly fitted, it can give you some protection. And basically, the surgical mask that everybody was wearing around was virtually no protection.
Yeah, so viral aerosols are microscopic, so they're tiny. Respiratory droplets are a little bit bigger, so if you sneeze and you cover your mouth, some of those respiratory droplets will, some of them, not all of them, will be trapped, but viral aerosols are tiny, and a cloth mask is not capable of stopping them. Plus you have the air underneath. Typically, if there is, in hospitals, they have specialists that fit providers with masks, and typically you only wear them for about a half hour, and they're higher quality masks, and it doesn't mean that you're 100% protected there either, but obviously they're more effective. Cloth masks in schools with children, especially, who are touching, pulling, and even if they wear them perfectly, they're just not gonna offer that benefit. Yeah, that, you know, and if they would have worked, great, but when they don't, and that's covering children's face that we know are causing learning loss and other issues, that's a problem. They also rejected concerns about masks not affecting your child's ability to focus and learn in schools. Again, they just rejected the concerns without evidence, and there was no evidence that masks caused delays in language and development of speech, again, because it was never properly studied. So they're just denying that there's a negative impact. Now, going back to your question of quality of evidence, if we look at the bottom of the triangle, observational studies and models are at the bottom of that triangle, and an expert opinion without evidence should be off the triangle. I just put it on, I just put it at the bottom of the triangle. And then one of the most recent, strongest studies is the Cochrane Review, which they took 78 peer-reviewed studies, and they determined what I suggested before, that cloth masks do not offer a meaningful public health benefit, and that would be at the very top of the triangle. So you're always going to have conflicting studies to a degree. Again, methodologies in the same way with data criteria are really important to look at. But when we look at a body of evidence, that's how we make determinations. DHEC is continuing to strongly encourage everyone who learns and works in a school setting to wear a well-fitted mask consistently and correctly when around others. This was still up on the DHEC website from a couple of days ago. I wanted to show this. So DHEC gave K-12 guidance for schools. I don't know if anyone saw this in this document. They would publish these every so often. This is the contact tracing paradigm, I guess, they use. If we look at the green germ there in the middle, that's an unmasked student who's positive. And then based on the distance a masked child or an unmasked child was away from them, between 2 and 4 feet, they were kept out of school for up to 10 days. So this resulted in learning loss, social isolation, and other issues. And I couldn't find any citations or any body of scientific evidence to support this at all. This is another one. This is a masked positive student there in the middle. And then you can see masked, unmasked, between 2 and 7 feet. So it's very illogical. Clearly this would erode parents' public trust in DHEC when their child's being kept home from school. And it just clearly doesn't make sense to, I would say, most parents. So to build back public trust, amend Title 44-150, remove language fining or imprisoning a person for not complying with a DHEC regulation in an emergency. And other things too. And then perform a legislative assessment, and South Carolina taxpayers are getting a good return on our investment in DHEC. Thank you, and I welcome any questions.
Yes, Senator Gary.
Thank you for being with us today. Thank you also. I got some of these documents from you from your clip. You know, I sit down, I read about 10 of those studies, which is basic information, you know, say the first woman was 26 years old, female, et cetera, et cetera. But I saw no analysis anywhere. So, I mean, all that information was great. I mean, I'm glad to hear about it. There was 910 of those reported. But I saw no analysis anywhere. Are you telling me that South Carolina didn't analyze the South Carolina people that died or had problems from COVID?
So that just based on, and you can ask them this question, but based on my conversations with the FOIA response, they stated that it was CDC and FDA's responsibility to monitor and investigate.
South Carolina people?
Yes,
our
South
people,
Carolina.
our citizens,
yes.
Our constituents, it's the government's, the federal government's responsibility.
Yes. So, well, that's what DHEC was stating, so basically that they were leaving it up to the federal government to investigate those injuries and deaths. Yes.
Our businesses could have been charged $1,000 a day. Our people could have been in prison for 30 days for not complying. And so all of this is being done out of the federal government, and so the state government, as far as you can see, you found nothing to show us otherwise. That anybody at DHEC even did any studies or analysis on our COVID deaths, our COVID injuries.
That's right. Yeah.
Is that what you're telling me?
Based on what they communicated, that's correct.
Thank you. And thank you for all your work. This is really good information and really helpful for us to talk about maybe next steps for us legislatively. You did very briefly mention HR within DHEC, and I wanted to know if you had seen the recent report that was published by the South Carolina Legislative Audit Council that talks about HR within DHEC and has a number of what I would call deficiencies that that we need to go and fix. I was just wondering if you are aware of that most recent report. No, I have not seen that. Okay, if you got a minute and were able to take a look at that, I would appreciate that. Thank you.
In all of your FOIAs, did you run across any times or evidence when the CDC was pushing something and you found where DX said, oh no, we're not going to do that, or was there just no evidence of that? It just seemed to be whatever they were saying. And I'll ask DX this, but I'm just wondering if you ran into any evidence.
So based on, for the masking, they did say, they did say we adopted CDC guidance on this. And then just through my own analysis, and I did talk to the director about this in our meeting, so this document, this is a DHEC document, but much of it, not all, but the majority of it was adopted from CDC guidance, or K-12 guidance. Also, the vaccine rollout was very, similar messaging to CDC. So yeah, a lot of state agencies do that. We have qualified people, with masters of public health. We do have employees that are qualified in our state who should have the ability to do this. But many states do depend on CDC, and they just, again, maybe it's the same as when a provider assumes that DHEC has rigorously vetted something, so they feel very comfortable that something's safe and effective, and that they should pass on this advice to their patient. It could be the same sort of thought process with our state health agency and CDC. So that would be a good, I think, conversation to have.
Yeah, I mean, especially after the last testimony, it's like we know that they weren't doing, the CDC and FDA and everybody was not doing their job, even with childhood or with COVID or whatever. And so I guess my key question is, did DHEC just, first of all, are they even aware that the FDA and CDC are not doing their jobs at all? And are they just taking stuff and forcing it here and not even, checking into it? And so, I'll ask them, but I'm wondering if, when you're investigating, did they say, oh, well, yeah, we know there's concerns, and they have said some things, but we didn't push those, or did they just kind of say, yeah?
Well, you can, I don't want to speak for Director Simmer, but I brought that up, and he did say that, they didn't adopt everything. So he gave me a few examples of that, so he'll be able to explain that. But that's exactly why I started doing the FOIAs, because I have a young child. This started when she was in preschool, and just, I couldn't really wrap my brain around some of the policy determinations and the science, and the data was a little more inconsistent with other states and global data. Yet the media, and they're just picking up what DHEC is saying is messaging people, and it was a very panic, and so that's what caused me to reach out, because it just did seem like it was kind of like a top-down approach.
Dr. Gilpy, thank you so much for all your research and your effort into this matter, and thank you so much for coming today.
Thank you.
Anything you want to submit, please get it to Mr. Brilliant here next to me, and he will make sure that we all have it and it's entered into the record.
Great, thank you so much.
Colleagues, we're going to need to take a 10 or 15 minute break here. I think our tech folks are needing to do a little catch up on some things coming up. So if we could just take maybe about a 10 or 15 minute break, and then we'll resume.
What's next on the schedule?
I think about it, we first started in this about 2 years ago, trying to get this kind of thing going. And I really appreciate the amount of work that Senator Portman did. It's a tremendous job to pull something like this off. And we're all part-time legislators, and yet we was able to do it. But on the other hand, it's 2 years in which people die. People have been adversely affected, and nothing has been done. And when I get done showing you the corrective actions, I hope you understand that you have some responsibility in what's happened. And I apologize for saying that right off the front, but that's the truth, and that's what we have to get to. We have to get down to the truth. I'll start with C. I gotta make sure I know how this goes. Okay. I have a background of, I was a program manager at IBM, in semiconductor design, manufacturing, world standards, manufacturing methods. All of that was where I developed sorry, I can see where the mic is going now. I was a program manager, which means I did the project management kind of stuff, but I did it for large projects. I was in also, believe it or not, for Spartanburg Regional, I was the CIO for part of Spartanburg Regional, bringing up a greenfield, bringing up North Grove from the ground up. And that included installing the EMR, getting it working, all the diagnostic tools, all the databases. I also have a PhD in biophysics as well as AI. I've been 60 years working on AI. So as an analyst, I have an unparalleled amount of experience in that area. I don't think there's anybody yet alive that has the amount of experience I have in AI. My assignment here, I was on the school board for 10 years, so there's an education part to my presentation as well. My assignment here is to be a CIO. And what I'm doing is I'm assessing the performance of the COVID era by the South Carolina government, particularly DHEC, but by the South Carolina government, both in terms of the science and in terms of the management. One of the things about root cause analysis is that you do root causes. Usually root causes come at the end, but come nearer the end of the process, but we've already done a lot of observations by which you get the root causes. So I'm going to specify 4 root causes to begin with. Then I'll go back to some observations. Then I'll come back to more root causes, and then I'll come back to the corrective actions that need to be done in the legislature in order to fix the problems that you've heard from the observations. Okay, so I'm going to talk first of all about the mother of all the root causes. So if you were to make a hierarchy of some kind, we got a family of root causes, but there's some that just pop out at you that you have to say them at the beginning. Put them at the end, you're going to forget them. These are the important things. The most important thing is that the government of South Carolina, the healthcare systems of South Carolina, the education systems of South Carolina, the politicians of South Carolina, and the political parties of South Carolina have lost integrity in the sight of the citizens of South Carolina. Somehow we've got to build back the integrity. What is integrity? According to C.S. Lewis, one of my favorite authors, C.S. Lewis says it's doing the right thing even when no one is looking. Integrity is a foundation of moral virtue and the bedrock upon which good character is built. Acting with integrity means understanding, accepting, and choosing and living in accordance with one's principles, which will include honesty, fairness, and decency. A person of integrity will consistently demonstrate good character by being free of corruption and hypocrisy. Integrity is revealed when people act virtuously, regardless of circumstance or consequence. This often requires moral courage Indeed, integrity is the critical connection between ethics and moral action. What we've seen, what the people of South Carolina, the citizens see, is a loss of these principles that have been defined here. Politically, what this means is doing what's right, even if it means not taking money from big pharmas or the feds. Well, the father of all root causes is the phrase, keep it simple. The problem with what we're experiencing, what we've experienced in the last 2 years is it's not simple. It's complex. It requires multiple disciplines to even understand the language, let alone understanding how they all fit together. But what people ask me to do is, I don't have time, keep it simple. To me personally, they're lazy. Well, but that's because I have a lot of experience. But to me, they're lazy. In fact, they don't have the education. So I'm going back at the end and saying education is a primary problem here. Because in this generation, if you've read the fourth turning, this generation we're in right now is the fourth. And this is the generation we live or die by for the next 100 years. Keeping it simple is an excuse at this point. Another root cause is ethics in itself. This is what Robert Malone says. What is the overall arc of the COVID crisis? I suggest 2 words, perspective and ethics. Many lost their ability to maintain an objective perspective, to accurately assess reality, partly because their mental and psychological space and reality was actively manipulated using a variety of Orwellian modern psychological manipulation methods employed by governments, financial organizations, industry, particularly pharma and the media, and non-governmental globalist organizations like the Gates Foundation, WHO, WEF, and the UN. But above all, and beyond even this, was the wholesale jettisoning of any and all commitments to fundamental ethical principles. So here's one meme. Can the public ever trust science again? The follow-on speaker will talk about this in more detail. But the fact is that right now, we can't trust because what we're seeing is contrary to what the science person has said. And here we've got another meme. Just because I've been wrong about everything doesn't mean the guidance is invalid. And the lady's saying, actually, yes, that is exactly it. So now I'm starting with the observations, this process of root cause analysis. So I'm starting with the observations. Start with the virus itself. They told us it was not lab developed. They had scientists sign off it was not lab developed, the same scientists that developed the processes in the first place. We were lied to. It was a wet market, various animals. Experts claimed it wasn't the source. And we as South Carolinians were not at fault. We had nothing to go on but what the corruption in the federal government said it was. We were blindsided. What if we'd known right at the beginning that this was man-made and developed? And then what if we'd known that the actual solution had already been printed out in the laboratory and was ready to go? How would we have handled things differently? Risk management and an understanding of human nature suggests that because all this has happened, we've got to expect that it's going to happen again. And so we have to have a plan in South Carolina where we can have some control on how we can stop the processes that we've seen happen. In creating the virus, which there's going to be another one, there's going to be another one, and then we're going to go into climate change, and we'll have the same mechanisms for climate change. We've got to look at this whole system that they've built and dismantle it at the state level so that we're safe. Was it effective? Government trials were theater. Effectiveness stop the spread was never proven. Now, if you read the Pfizer papers, which I have, I had a part in the writing of those Pfizer papers, you will see that all of the Pfizer experiments that were done were faulty in one way or the other. And where they weren't faulty, they exposed the adverse effects, but they were never reported. I'm going to explain in a minute exactly how all of this worked, the secret underbelly of all the questions that were asked at the beginning by Aaron, and all the questions you've been asking now, how that actually occurred. How did they pull this off? I'll read this quote. How could the mRNA vaccines have looked so good in the fall of 2020 with greater than 90% efficiency in preventing COVID-19 and no serious safety issues, and then the next few months after release have the bottom fall out with massive breakthrough cases, horrific injuries, disability, and death? Well, that was part of the Pfizer quotes. And now we're required to take multiple boosters. And those boosters are being less and less effective, and people are getting sicker and sicker. How could that have happened? This was another little meme I came up with. In May, we had 95% protection. In June, we had 70%. In July, we had 50%. This is going back to 2021. In August, we had no protection, but we reduced the spread. In September, it doesn't reduce the spread, but it reduces the severity. In October, it doesn't reduce the severity, but it reduces hospitalizations. In November, it doesn't reduce hospitalizations, but you aren't going to die. And in December, you die, but you go to heaven. This is probably the best graph, unbiased type of graph to show you the effectiveness of, what do I say there? Cumulative incidence of COVID cases by number of doses of, and then what's that psi? Why is that there? Because the mRNA was not a real mRNA. It was a contrived mRNA. It had pseudo-uridine instead of uridine, which meant that when my assumption, I had to go on a trip, and so I had to get the first 2 shots. My assumption when I first read the literature about the shots, well, it's mRNA, so it's gonna be broken down rapidly in the body. Well, the psi means that it's not going to be broken down rapidly in the body. It's hardly going to be broken down at all. It's going to have a difficult time because of the psi. And they had other things in there too, but it made it very difficult for that mRNA to break down. This is a picture. If you look at it, down at the bottom, if you had 0 doses of vaccine, and this goes through several of the different stages of the virus, then you had the lowest chance of getting COVID. And then at the top is, if you had greater than 3 doses, then you would have that kind. This is cumulative, so it adds up by the x-axis is days. So it's cumulative, and the more, basically it says the more doses that you get, the more likely you are to get sick. So was it safe? This is a shot off of the DHEC website for July 18th. And the DHEC website says the vaccines are safe, effective, and free. Now we'll go, well, that was effective. Now we'll go into safe. These data have been reported before. The CDC data show that 7.7% got sick. And they had to visit the IPR or be hospitalized. What he didn't show you was after that, 15% of those that got sick really had a medical problem or disability that affected them for the rest of their life type of issue. This is not just in the U.S. Now, I want to make it clear that we kind of talk about U.S., but there's better data around the world on some of this. And I have gone all around the world, and I've written a book that I will provide to you that gives you all of the data, sources from around the world that would be helpful to you in understanding and have good front ends so that you can begin to understand. Like Australia, like New Zealand, like Israel, like England, like some of the Scandinavian countries, they all have front ends and they've all tracked it better than the US has. But it's also true that they've shut out, by now they've shut a lot of those data out. So it was up to people to capture the data before they actually removed it because too many people were catching on to what was going on. And so you have to go to other places to actually find the data. The adverse effects long-term, I'm going to go into those in some detail, but the circulatory systems, the nervous system, the reproductive system, that's my most concern, the female reproductive system. The immune system, cancer, skin, kidney, digestive, all of these have ACE2 in them. You know, ACE2 is the thing that the spike attaches to. I'll show you another in a minute. This technology was developed under DoD contract. It's a countermeasure. It's a bioweapon countermeasure. You look this up. Go and look up how you get reimbursed for vaccine injury. And you have to put in COVID-19 reimbursement or something like that. And you will see the title of the page is countermeasure reimbursement. They don't call, in all of the contracts, I've gone through all the contracts, in all of the contracts, they do not call this a vaccine. They call it a countermeasure, a bioweapon countermeasure. And I will go through a little bit later and show you the detail in the actual contracts of how, of the wording of how they got this through and why there was no decent testing and why the FDA says what it does. So in summary, if I've read thousands of scientific papers, I read 10 to 20 a day. And I've done that for the past 3 years.
Dr. Lee, let me interrupt you 1 minute. So am I to understand that the Department of Defense is literally and openly calling this a bioweapon?
They're calling it a countermeasure, a bioweapon countermeasure.
Okay, in reference to the vaccine or to the
vaccine?
Okay, so if the vaccine is a countermeasure.
That was all a flim-flam. That was all a lie.
To a bioweapon.
Yeah, it was actually under the bioweapon process.
Right. So are they claiming that we were attacked by China through a bioweapon? I mean, that's kind of what I'm gleaning from this. I'm sure nobody in Washington's going to stand up and say that.
No,
I just want to see if I'm reading correctly what you're sort of inferring here.
That's not an inference. That's how they treated it.
Okay, thank you.
And I've got the contracts in another book I wrote that I can provide.
Well, I trust you on that, Dr. Lee. I know that for several years now, I don't know of anybody who has researched this matter more than you.
Thank you. Now, from all these papers, what you get is that the vaccine is actually a tool of accelerated aging to most of the received it. That is, if you've received it and it's proportional to the number of shots, it accelerates your aging process, which is another way of saying that statistically, according to insurance companies that would do the analysis on it, they will be charging you more they should be charging you more depending on the number of shots you have, because you are at greater risk of death depending on the number of shots you have. The UK, the disability system in the UK is called PIP. And this shows you something. This is how you get to some of the data, because one of the key things you get from this is the data that we have sucks, and it's nothing you can make a decision on. And we have to do something about that. We can't do it at the federal level because they've got control of that. We actually can't do as much at the state level because they're messing around at the state level with the data as well. As you've already seen, we've got to be very careful on how we pull ourselves out of this so we don't fall into a deeper trap of other people controlling our data, our health data. So these are the data. Isn't this interesting? Hematologically, between 2016 compared to 2016, 2019, and this would be the 2022 end of year stuff. Hematological disabilities are up 522%, auditory disabilities are up 121%, cardiovascular disabilities are up 128%, dermatological disabilities are up 138%. Now, for each one of these, I can give you a reason why. I can go into the biophysics, which is the actual biology of why this happens. But I'm not going to do it because I don't have time. But it's very interesting. It's very difficult to understand. I've had a lot of help. Endocrine, gastrointestinal. Just look at that. Look at the numbers there. These are numbers that are more trustworthy than any of the numbers you get out of theirs. Because this is actual people filing because they've got a disability. And this is how much tough things are. And you notice that's UK. Now, we haven't talked too much about foreign. Foreign information can often be the best. This is a chart that you should take away with you. You know, drugs are recalled when there's a number of adverse events. Right? The top one is polio. After 10 adverse events, the polio vaccine was pulled. I remember that. I'm old enough to remember that. The swine vaccine of 1976, it was pulled after 53. Go down the list. Vioxx, this is one some of you might remember. 6,637 adverse events, and it was pulled from the market. What do you think this red line down here that isn't pulled from the market? It's the COVID vaccine. It's the mRNA vaccine. We're at when I put this together, we were at 35,646 deaths by bears, which you know is low, and it hasn't been pulled from the market. And go back and figure out why. I mean, I don't have to hint too much as to what's going on here, but I'll say it out loud in a minute. Okay, so I call the spike a mod spike because there's a real spike. It's a fake. It is not the real one. It's one that can survive all by itself in the blood. It can circulate in the blood. It's been seen to circulate in the blood as long as they've been able to measure it, which is over 6 months. Usually when it circulates in the blood, it circulates with a little fat around it. It's called the exosome. But it's like two bubbles. Here you got a cell, it's a bubble. Here you got a bubble that's the spike that got 3, or the mRNA that got 3. You know what bubbles do when you blow your bubbles and the bubbles come together and inserts the spike into the bigger one as it comes together. These are where ACE is. ACE2 is free in the blood to begin with. And ACE2 is also very expressive on cell surfaces. All cells make ACE2. But some cells actually express them on their surfaces. That's what comes on this spike gets in there. It joins to it. It has a little end that joins electrostatically to the cell membrane. The S2 part of the spike kind of makes it join, then it breaks off, and then the S1 part of the spike, there's 3 parts to that. That opens up, comes in, brings it right in. So, I got that right. So, look at the highly expressive. That is, there's a whole lot of ACE2 in the duodenum, the small intestine, the kidney, the gallbladder, the testes, the eye, and the heart. Moderately expressive in the seminal vesicle, placenta, and colon. Low expressive in all those other things. So we should be expecting, this is just talking about the spike now. I haven't even talked about the lipid nanoparticles, which have the biggest effect in the female reproductive system. It's all over, and once you get the the mod spike, which doesn't break down, floating around, it'll get in and go in, and you know what it does? You heard of mitochondria, some of you heard of mitochondria. It tends to attack the mitochondria, and it makes the mitochondria so it doesn't produce as much of the energy factor. And what do they call long COVID again? What happens with long COVID? Can you get an idea of what's going on here? But again, the reproductive system is a concern, and eyes are getting to be a real concern because more and more this happens gradually because you're producing it all the time, because the mRNA is not going away. It's getting trapped in your lipids, in your lymph system, and it's still producing the spike. This is a graph I will not take much time on. This is a flow chart that shows you what happens to the mRNA vaccine. You have the mRNA, it has liquid nanoparticles, it has the mRNA particle, and that can be naked or encapsulated in the extracellular vesicle over there on the right is what it's called. The exosomes, and it can float in your bloodstream for two weeks or more. You get the liquid nanoparticles that can be in the bloodstream, they can get into the lymph system, they can get in the central nervous system, they can get in the testes, they can concentrate in the liver, they can concentrate in the spleen and in the ovaries. And potentially that can happen to life. And these are not natural particles. These are man-made stuff. They're almost like plastics. Now on this chart, they didn't show, I pulled this off of a website, they didn't show what happens after the cell gets infected. When a cell gets infected, it can either die because it doesn't function right, it can get absorbed by a phagocyte, or it can send its own signal that says, I'm gonna die. And they actually have that, every cell in your body has that. You die now. And it'll produce a certain protein that'll kill the cell. What happens to everything that's in it? All the spike that's in it, all the mRNAs that are supposed to be in it, what happens to it? It gets into the bloodstream. It gets into the lymph system. It floats around. It doesn't get destroyed. It gets these exosomes. It goes into all the cells around it. It floats around. You can't get rid of it. So down here at the bottom, I've got the fact that when the cell dies and breaks apart, you've got this mRNA, you've got the mod spike, and all the different kinds of fragments, because some of it has already been broken up inside your cell because your cell noticed it's bad. And it's now floating around in DVDs, and it's floating around inside other cells. Folks, this was not made to help people get healthy. I'm not saying it was a weapon, but what I'm saying is there was a whole lot that was missed. We're talking about ethics, we're talking about what was driving people to do it to begin with. Now, you can only get in people's heads a little bit about what happens. I also wanted to mention that the lipid nanoparticles can be excreted. Matter of fact, that's how they tell in cities. They look at the sewage to figure out how bad the infection is. The liquid nanoparticles can be excreted in the feces, and urine, and saliva, and sweat, and maternal milk, and they don't know whether it's excreted in the semen. The mRNA, when it gets encased in the EVs, is present in human maternal milk. And the spike is present on your skin. This is just coming out. It gets caught on your skin, and then you can rub it off on somebody else like the baby. And that's been seen 3 months after injection. And the penetration of the vaccine means that it can be passed transdermally. That's what I was just talking about. It can be passed by inhalation, that is, that people that have been vaccinated are the pandemic of the unvaccinated. They're the ones that are the problem. Now, my thought is there isn't enough, if you've had the infection already, there isn't enough of the virus or the particles of the spike or anything else to cause you a problem. But it could cause a problem to somebody that has already had a shot. By the way, these, both the mRNA and the spike can go through the placenta and are detected in the baby. How about the mandates? The mandates, it's been talked by Denise before. The mandates here in the state are done by serious suggestion by DHEC. But there are motivations that go beyond DHEC of why the mandates happen. And the list is kind of just a partial list. Department of Labor, there are requirements for doing business with the government, and those requirements are you have to wear a mask. Healthcare, all the healthcare requirements, because of Medicare and HHS funding, and specifically Medicare, that's why we had to wear a mask for so long in the hospital. It wasn't because of a medical thing, it was because the money had conditions attached. Education was due to the unions and federal funding. Plus there was misinformation. You've heard Denise's story about that. This seemed to be very arbitrary, and it favored the big box stores, and you just have to ask why. And again, it's a follow the money thing. This all becomes an issue of integrity. Was the COVID era a proof of concept? Should we expect it to reappear both for disease and for other population as a psyops campaign? And that has to do with mandates. DHEC, you've heard it, DHEC failed at its basic task, accurate guidance. I've seen no commitment to fix it. You have not seen the fix on their websites at least. They're unable to provide transparency on the validity of data used for hospitalizations and deaths published on the DHEC website. They're unable to provide adequate evidence for universal masking in South Carolina schools. They're unable to provide safety and adverse effect data to recommend regarding the recommendation of universal pediatric vaccines. They did not evaluate and act on the nearly 9,000 COVID vaccines in theirs. They didn't react to other countries' data. They didn't react to U.S. data. They don't appear to have a mission of adverse effects. I wonder why. They also have explicitly stated that they don't care about the job, the financial, the psychological, or the education effects. Their mission is education, or is health. Other disinformation was manipulation of the language, censorship of speech, medical. I'll talk about this in a second. Medical organizations control what the doctors could say. And you've heard the story of that, but there's actually a paper trail. It's a money paper trail. In general, we have a government control of our lives through control of federal funding to state and local institutions with strings attached. So the money we are receiving to reduce our state budget that comes from the federal government has strings attached, and those strings are what cause a lot of the problems we have. And you can look at some of the problems on the DHEC website. So, was it safe? And now we're getting into the follow the money. There was just systemic healthcare corruption. They first initiated protocols that killed, but they were profitable. You can see here, a patient put on a respirator, $39,000. Know what the respirators did to people. The remdesivir thing, where the remdesivir has caused all kinds of problems, all kinds of adverse effects. It's worse than the countermeasure. I was going to say vaccine, but countermeasure. Healthcare systems, money received for each COVID case averaged $186,000. For DHEC, their funding, 44% came from either federal COVID support or state COVID support. Guess what was attached to the money they received? And really that's part of your responsibility, because I'd like to know where the approvals came so that they would accept that money, but nobody looked at what was attached to the fund. Now, FOIA has revealed that there was $13 billion that were spent on influencers to promote injections. And here's one example that is egregious. $11 million was given to a for-profit OBGYN NGO that oversees tens of thousands of obstetricians and gynecologists on 2 continents. They required the return of funding if the medical organizations did not adhere to the safe and effective message presented by HHS. So what we can say is that if you wonder why any of this that happened in the last 2 months happened in the health industry, in the media industry, it's basically around money. Follow the money. But also follow the corrupt individuals. And we have some corrupt individuals that I could identify by name in the executive branch at this time. There needs to be some cleaning done there. There's no integrity at the federal government, the state government, the healthcare organizations, the physicians, the corporations. Now I say that no integrity, I mean, it was enough to cause the decisions that were made. Now we had great physicians. I had a great physician that despite being in a state healthcare organization gave me what I needed to have, which was illegal. He would get fired. You'll hear about that later. And we had $400 billion that's stolen or wasted, according to Fortune magazine. This is one I want you to pay attention to. Basically, there's been a succession of laws over about 50 years that set up a situation where there were public and private funding streams for military-led biological, chemical, or neurological weapons research, development, and deployment programs. They were sold to Congress and the public as public emergency programs. So that's how this all came together. And the private funding was pharmaceutical companies. The public funding was budgets to DOD. Basically, the laws shield government funders, developers, and regulators from criminal prosecution by classifying what they were developing as communicable, scheduled toxins, communicable pathogens, and so on, so that these weapons were considered to be defensive or protective. And another law eliminated informed consent by reclassifying those that carried the disease as a national security threat. So in other words, when you have the disease, you're not entitled to like insurance or payment for your problems because you're considered a national security threat to them. And you will see on that page where they provide, allow you to submit an application for some of the expenses for an adverse effect, you'll find that there's been thousands, I think there've been 9 cases that have been paid off. The products that are produced, the vaccines, are protected from liability. And part of this is if you read the contracts, and this is so important, if you read the contracts were actually written, and by the way, the contracts go to a shell corporation, so that they're kind of quote hidden from tracking. They go to a shell corporation, and in that shell corporation, if you read the contracts that were gotten by FOIA, you find there's no safety or efficacy standards that are required in the contract. The only requirement in the contract is that the FDA approve. There's nothing said about quality, nothing said about safety, nothing said about ethics. Just get it past FDA. So, okay, just get it past FDA. Now you go over to FDA and say, you gotta pass this. This is a DOD thing. So why weren't all the tests done? Why weren't they done right? There's your answer. It was never a requirement. Now in manufacturing, 25 years of manufacturing, you have specifications. Specifications require what you have to do in the manufacturing process. Okay. So the warning here is it's unaccountable and unauditable. In the near future, we expect more. This was written in late July. But we expect more shots to be required. We expect, because of the 9,613 patents on mRNA technology, we expect more technology. As a matter of fact, there's 40 mRNA cancer vaccines under clinical trials. And we expect a lot to come from food in the next year. And part of that will be that we will give up our decision-making process in terms of whether it's a pandemic and whether emergency laws are required like mandates. That will be dictated by an organization inside food. Root cause analysis. Now, this is the root cause analysis. You have observations. You look at the decision and command change. You look at workflow weaknesses. You look at action outcomes. You look at ethics evaluation, and you look at prioritization for root cause analysis. Then you do your root cause analysis. Then you do your lessons learned. Then you have a corrective action plan. And that corrective action plan has to look at process, personnel, chain of command, and control. This is the root cause in terms of human ethics, evil, greed, pride, and power. That is one major root cause. Mal and disinformation from the government, military, science, media, pharma, and oligarchs. Lack of accurate information on the SARS data, the test data, the effectiveness, the adverse effects, and there was missing science in this whole thing, science that wasn't done, science that was done that was defective, and the medical protocols. And a lack of desire for quality. The development process, poor manufacturing practice, poor logistics, and poor training, because none of that was required. Lessons learned. Well, right now, from the citizens of South Carolina, the lessons learned are we can't trust the government. We can't trust the U.S. government. In general, we can't trust the deep state, especially the three-letter security agencies and HHS. They seem to be deeply involved in something that's illegal and immoral. We can feel it. We can't put our hands on it, and we're just beginning to. The U.S. was developing bioweapons and other pharmas overseas in China, Ukraine, Southeast Asia, and so on. These can't. Well, let me go on to the thing. The state, South Carolina, has to be the place where these problems are solved. Corrective actions. So I'm going to go through this list. I'm going to kind of repeat them. If you want me to say more about them, then I will. We need to understand where DHEC is in terms of its own root cause. Do you know that DHEC requires root cause analysis of everything that it does? But has DHEC done its own root cause analysis? And it has to be transparent. We have to see it as citizens, and everybody in the legislature needs to see it. And the governor needs to see it. we need to establish data that's reliable. And this means that we need to establish a state disease management system. This is our very top priority. Is if we're gonna make decisions that we have to have data to make the decisions on that's reliable. And it can't be controlled by the federal agencies. As you see down the bottom, independent of the federal agencies. It also can't be controlled by DHEC. Because DHEC is, well, there's no integrity right now. Maybe it can be controlled at DHEC sometime in the future, but generally, the process that's been set aside is kind of been set aside, standardized, it's called the RIO, where you establish a politically free state effectiveness and adverse effects database and management structure, something outside of politics, where you have a committee that runs the RIO and a database, and the database pulls real-time information from all of EPIC, from all the sites that have EPIC in the state, and tracks them for adverse effects and for effectiveness. And we've got a detailed design. We have people.
Dr. Lee, I think the Senator Greenwood has a question.
Briefly, just want to know if any of these have been established anywhere, is quasi-government,
Yes.
Have any of them been established anywhere in the United States?
Type in RIO.
Yes. Thank you.
There's also the databases themselves, which there are a lot of. Here's the problem. There's already money, from what I can tell, in NIH. And indications in the FDA that they're going to impose the same structure on all the states. But then they will have control of the data. And I don't know if you know this, but in VAERS, a lot of data has been pulled out of VAERS. The data that was destructive to their message, they pull it away. They have control over it. We do not want control. We want a database that's controlled independent of any political entity, that any person can do their own analysis so that we have people that are interested can go in and do an analysis so that we have multiple people looking at the database for different interests. And that would include DHEC could have access to the database any way they wanted to, but they would not control it. The next thing we need to have is, we need to have our autopsy methodologies changed. We need to have criteria for people that die suddenly, or people that die that look like they died from adverse effect. They need to have an autopsy so we can understand at the back side of this what the ICD codes really mean. We need to establish the criteria for identifying when an autopsy is needed, and we need to establish the methodologies that are done to perform that autopsy. Now, this is all pretty much established in various organizations, but it has not been established in this state. And I've talked with the Greenville coroner. They're happy to do this. Of course, they would like to be funded. DHEC has a responsibility to critically review all NIH work products. DHEC has the responsibility to do a quality examination of vaccines and other pharma products, regardless of FDA approval status. That is, all the FDA looks at is, if they were to look at it at all, it's the manufacturing. They don't look at the transportation part. The problem, a lot of the problems I believe that have occurred with the COVID vaccine, other than its basic design, is that the COVID vaccine had to be kept cold from manufacturing till it got into the person's body. There's no tracking of that. And as soon as it varies in temperature a little bit, anywhere along the process of logistics, things start breaking down and you're not getting the product that you got in. And you can see from the data that there's a very wide variability in the vial to vial. By the way, they don't track to the vial. They only track to this big package. So you won't even know how the individual went in and got a shot, we have them all around the room, we're sitting there, how are they warming up? What's happening to those vials? There's no tracking of the vials. DHEC has to correct their website. They need to stop mRNA technology products are being used in South Carolina in food, in pharma, in human, in animal, and agriculture products grown in the state. We have to improve the informed consent process. The informed consent process, as you saw, is not complete. It's not something that an individual can read right now. We need to have a critical review of vaccines in the childhood vaccination process. I'm just repeating Denise's. And we need to have a new public health process, a new DHEC infrastructure in place. This is the infrastructure we have today. We have big bad wolves, executive orders, FDA regulations, CDC, guidance, and money from the farmers and the feds. It's all going into DHEC. Now, I've said regs. As Denise said, they're not regs, but they are. Let's face it, everybody's taking them as being regs, and the result is a lot of problems. That disinformation is also going to the governor. He's making decisions that he shouldn't. That's also going to the DHEC board, which I understand no longer exists, but it's also going to you. And so, in terms of integrity, trust, accountability, and performance, we've got a system here that's built not to have any of that. So in order to provide that, we have something that is already passed up right at the end of the last session. We called it a directive, but what we need is a Florida Surgeon General. We need a politically responsive, that is somebody that we can hold accountable, Surgeon General, that is of leadership quality, like Florida Attorney General, that can provide guidance to you and to the governor in a way that the people feel confident about. Blood donations. We don't do anything with blood donations today, and we're getting long. And in the UK, they stop blood donations of anybody that has long COVID symptoms. What we need is blood tests for the spike in lipid nanoparticles, because you've seen in both cases that at least 6 months later, there's spike and LPNs in blood. We need to make statewide and regional mandates illegal. We need to have pharmas be off campus only. They're coming on campus, they're giving lunches, they're visiting doctors' offices. They should not have that. We need to also not allow doctors to get $3,000 a night for a 45-minute speech type of thing, where they're indebted to the pharmas for their livelihood. And we need to get pharmas off the state media. We need to have transparency in financial dealings from pharmas, healthcare organizations, health NGOs. Basically, that means we need to examine what's happening with legal fees, legislature, executive branch, and we need to slam the revolving door shut. We need to get rid of federal digital money, because that's the way they're going to control us in the future. We need to have a situation where, if there are federal mandates from administrators or presidential executive orders, they are reviewed by the Attorney General to determine if they're constitutional. If they're not, then those mandates don't apply to the citizens of South Carolina. All goods and services that don't have liability should not be permitted in South Carolina. This includes pharmas. We need to provide support to bring suits against individuals and organizations for malfeasance, dereliction of duty. We need to provide workman's comp that's paid by the employer if the employer requires a shot. We need to look into providing support for medical costs, personal injuries, and so on. or improper informed consent, and that's a major issue, is that informed consent needs to be reformed.
Dr. Lee.
Restore the healthcare provider's relationship to the patient.
Dr. Lee, hey, excuse me, untimely interruption, but when you and I first spoke, I asked you, I told you I would give you an hour to speak if you wanted it, and you said, no, I can do it in half an hour. And you've got a fabulous presentation here, but if you could move along, we have a schedule, we have other people, in certain time slots that, may have to get back to something else, so if you could wrap it up, we'd greatly appreciate it.
Yeah. Okay. Healthcare providers should not be able to express their medical opinions without fear of retribution. Healthcare providers should not be disciplined for discussing with patients care alternatives outside of mandated protocol. It's chiefly, here's a quote, chiefly upon the lay citizen about science, it's chiefly upon the lay citizen to learn about science but not its practitioner, that the country must depend on determining the use to which science is put. This puts us into the education area. We must be teaching the scientific method. We should teach what's happened in the SARS-CoV-2 as an example of the way processes are wrongly executed. We should teach critical thinking, and we need to do this for all ages. The clear failure of congressional investigation and oversight concerning these issues indirectly serves to validate the implemented patterns and policies, virtually guaranteeing that the creepy authoritarian totalitarianism deployed in the name of public health will be relieved and expanded during the future crisis response. Basically, we're saying that Congress, that this state legislature, in order to stop the process, needs to act. The good news is, the majority of everything I've talked about is already in the legislature. You just have to pass it. Thank you.
Does that conclude your presentation, Dr. Lee? Were there any questions? Dr. Lee, thank you so much. I know you and I have been following this and in communication since the thick of COVID. And I do want to give you huge accolades. You have put together more scientific information and sent to me, and I've been able to share that with my colleagues and so many people. I wish we had much more time to let you present, but thank you for what you presented. Gene, I know we're going in an order here, but is Dr. Philip Buckholz here? Are you under a time constraint, Doctor? Okay, could we shift gears and have Dr. Buckholz come up next? Thank you. I thought you might be under a time constraint. Thank you so much for being here. Dr. Buckholz, would you entertain questions as you go, or would you prefer
That's
that?
probably easiest as things come to mind, you can interrupt me. Okay. Don't know about things that are so a few. So a little bit of what am I doing here? For those of you who don't know me, my name is Philip Buckholz. I'm a PhD in biochemistry and molecular biology. I'm a cancer gene jock. Basically, I do cancer genomics research at the University of South Carolina. And what that means is that I'm kind of an expert on all the ways that the human genome can get futzed with during your lifetime, and which of those things cause cancer and which ones don't. Okay. So technically, that means that I'm very, very skilled in the art of DNA sequencing. Okay, I can figure out the sequence of things that I didn't know that I was looking for. And I'm also pretty good at, when I say I mean the people in my laboratory. You're not going to hear their names, but there's a group of people that do this excellent work. We're really good at detecting foreign pieces of DNA in places where they're not supposed to be, even if they're low levels. And we use those skills during the pandemic we invented the COVID test that many of you did a spit test. Okay, that came out of my lab because we were really good at that kind of stuff. And so I've earned a fair amount of respect in the state of South Carolina and in this body because we did a ton of COVID testing in the middle of the night when people were afraid, and we told them, no, you don't have COVID in your home, yes, you do. So my qualifications to comment on this are both technical and kind of relational in the state of South Carolina. I'll cut to a very narrow theme here, but it does touch on lots of these regulatory issues, and I'll leave it to you to expand on those if you want to. I'll try to stay in this narrow lane of some problems in the Pfizer vaccine as a case study for places in which regulatory oversight could be improved. All right, so first of all, let me say that my interpretation of the literature is that the Pfizer vaccine did a pretty good job of keeping people from dying, but it did a terrible job of stopping the pandemic. The early publications showed that it stopped infection, but that only lasted for like a month.
Dr. Burkhardt, could you pull the mic a little closer to you? Staff's still been having trouble getting you on the recording. Okay, thank you.
In my professional evaluation of the literature, the Pfizer vaccine did a pretty good job of keeping people out of the cemetery, but it sucked at stopping the pandemic. And it was the best of sucky options that we had. And I still believe that it was deployed mostly in good faith, but there were a lot of shortcuts taken because the house was on fire, and we could do a better job next time from the lessons that we're going to learn here. That's my own personal view of this, but I'm also, my philosophical bent here is, I'm sure many of you have heard of Occam's razor, right? Choose the simplest of explanations. Well, there's another one called Hanlon's razor, which is never attribute malice to that which can be better explained by incompetence. So I'm trying to be gracious here in many circumstances. There could be malice underneath, but I'm trying to see just incompetence to be gracious. The Pfizer vaccine is contaminated with plasmid DNA. It's not just mRNA. It's got bits of DNA in it. This DNA is the DNA vector that was used as the template for the in vitro transcription reaction when they made the mRNA. I know this is true because I sequenced it in my own lab. The vials of Pfizer vaccine that were given out here in Columbia, one of my colleagues was in charge of that vaccination program in the College of Pharmacy, and for reasons that I still don't understand, he kept every single vial. So the whole freezer full of the empty vials. Well, the empty vials have a little tiny bit in the bottom of them. He gave them all to me, and I looked at them. We had 2 batches that were given out here in Columbia, and I checked these 2 batches, and I checked them by sequencing. And I sequenced all the DNA that was in the vaccine, and I can see what's in there. And it's surprising that there's any DNA in there, and you can kind of work out what it is and how it got there, and I'm kind of alarmed about the possible consequences of this, both in terms of human health and biology, but you should be alarmed about the regulatory process that allowed it to get there. So this DNA, in my view, it could be causing some of the rare but serious side effects like death from cardiac arrest. So there's a lot of cases now of people having suspicious death after vaccine. It's hard to prove what caused it. It's just, temporally associated. And this DNA is a plausible mechanism. This DNA can and likely will integrate into the genomic DNA of cells that got transfected with the vaccine mix. This is just the way it works. We do this in the lab all the time. We take pieces of DNA, we mix them up with a lipid complex like the Pfizer vaccine is in. We pour it onto cells, and a lot of it gets into the cells, and a lot of it gets into the DNA of those cells, and it becomes a permanent fixture of the cell. It's not just a temporary thing. It is in that cell and all of its progeny from now on forevermore. Amen. So that's why I'm kind of alarmed about this DNA being in the vaccine. It's different from RNA because it can be permanent. This is a real hazard for genome modification of long-lived somatic cells, like stem cells. And it could cause, theoretically, this is all a theoretical concern, but it's pretty reasonable based on solid molecular biology, that it could cause a sustained autoimmune attack toward that tissue. It's also a very real theoretical risk of future cancer in some people. Depending on where in the genome this foreign piece of DNA lands, it can interrupt a tumor suppressor or activate an oncogene. I think it'll be rare, but I think the risk is not zero, and it may be high enough that we ought to figure out if this is happening or not. And again, the autoimmunity thing is not my wheelhouse. I'm not an immunologist, but the cancer risk is. That's my bag. I know this is a thing, and it is a possibility. Okay, a little nerdy science here. The central dogma of molecular biology is that DNA gets transcribed into RNA, okay? And then RNA gets translated into protein. This is just how life runs. Why does this matter? Well, DNA, for the purposes of this discussion, DNA is a long-lived information storage device. Okay, what you were born with, you're gonna die with and pass on to your kids. DNA lasts for hundreds of thousands of years, and it can last for generations if you can pass it on to your kids. Right? So alterations to the DNA, they stick around. RNA, by its nature, is temporary. It doesn't last. And that feature of RNA was part of the sales pitch for the vaccine. The pseudouridine was supposed to make the RNA last a little bit longer, but still, it's a transient phenomenon. We're talking hours to days, okay? And then proteins. Once proteins are made, they also don't last forever. They last for hours to days. But something that makes its way into DNA has the potential to last for a very long time, maybe a lifetime. So this is a picture of the sequencing run that I did in the lab from a couple of batches of the Pfizer vaccine. And all those little bitty lines here are the little tiny pieces of DNA that are in the vaccine. They don't belong there. They are not part of the sales pitch or marketing campaign. And they're there. There's a lot of, this little graph here in the middle is the size distribution, peaks around 100 base pairs, 120 base pairs. So the DNA pieces that are in the vaccine are short little pieces, 100, 120. There's some that are about 500 base pairs, a few that are even 5,000, but most of them are around 100 base pairs. Why is this important? Because the probability of a piece of DNA integrating into the human genome is unrelated to its size. So your genome risk is just a function of how many particles there are. So it's like, you know, if you shoot a shotgun at a washboard, if you shoot a slug, you have some probability of hitting it. And if you shoot buckshot, you have a bigger probability of hitting it with some shot, right? All these little pieces of DNA that are in the vaccine are analogous to buckshot. You have many, many thousands of opportunities to modify a cell of a vaccinated person. The pieces are very small because during the process they chopped them up to try to make them go away, but they actually increased the hazard of genome modification in the process. That's how this got here. In my view, somebody should go about sequencing DNA samples from stem cells of people who are vaccinated and find out if this theoretical risk has happened or not. I think this is a real serious oversight, regulatory oversight that happened at the federal level, and somebody should force this to happen somewhere.
Dr. McCall, are you capable of doing that?
Yeah, we do that kind of thing. But in order for it to be trustworthy by the public, this has to be done by lots of people.
I'll talk to you more about that later.
Yeah, this is our deal. This is why I know this should have been done at the federal level. Okay. So we took all these pieces of DNA and we used them to glue together what the source DNA must have been. This is kind of, again, this is what we do in the lab all the time. And all these little red and green lines here, these are all independent little pieces of DNA. This must have had 100,000 pieces of DNA in this sequencing run. And you can put them all back together and see what they came from is this circle over here. It's a plasmid that you can go shopping online to buy from Agilent. And it's clear that Pfizer took this plasmid and then they cloned spike into it. And they used it in a process called in vitro transcription translation, in vitro transcription. where you feed an RNA polymerase this plasmid, and it makes a whole bunch of mRNA copies for you. Okay, and then this mRNA, you mix it with the lipid nanoparticle transfection reagent, and now you've got your mRNA vaccine, but they failed to get the DNA out when they did it. So little pieces, they did some effort to chop it up, so all these little pieces of the plasmid got packaged in with the RNA. That's clear as day what happened just from the forensics of looking at the DNA sequencing. Okay. A little bit of a regulatory note here. The way you do RNA transcription, in vitro transcription reactions, you have to give it a DNA template, okay? And you can give it a DNA template that is just a synthetic piece of DNA that is only the instructions to make the RNA, and that's what was done for getting the emergency use authorization and the clinical trial. It's called Process 1, if you look up that kind of stuff. They made a PCR product of just the bits that they wanted, and then they did the in vitro transcription, made a bunch of RNA of that. There was no plasmid DNA to contaminate the stuff that was used for the trial. But making that PCR product doesn't scale the way that was necessary to vaccinate the whole world. So a cheaper way to scale up the production of this template is to clone that PCR product into this plasmid vector, put the plasmid vector into bacteria, and then you can grow up big vats of the bacteria. They make a lot of the plasmid DNA for you, and you use that plasmid DNA as the template to drive this transcription reaction to make your RNA. And that's how the contamination ended up in the production batches, even though it was not in the stuff that was used for the authorization trials. So I know it's a little bit of nerdy science, but it has regulatory implications for this. We can measure the quantity of this stuff pretty easy in the lab. We're good at doing this kind of stuff. This is the same. We made a little piece. A colleague of mine at MIT made, we used to work for the Broad Institute at MIT. He made a little PCR test, and we cloned it here. This is similar to the PCR test that you all took for the spit test. Okay, same idea, same expertise behind it. And we can quantify exactly how much of this stuff is in a vaccine or any other tissue. And I estimate that there were about 2 billion copies of the one piece that we're looking for in every dose. And if you look back at that map I showed you where it's all these the little piece that we're looking for is just that little bit right there, okay? But if you see 2 billion copies of this, there's about 200 billion of everything else. So what this means is that there's probably about 200 billion pieces of this plasmid DNA in each dose of the vaccine. And it's encapsulated in this lipid nanoparticle, so it's ready to be delivered inside the cell.
Make sure you get some.
Okay. This is a bad idea. My conclusions from this, we should check a bunch of people. We should check a bunch of vaccinated people getting tissue samples, especially if we focus on harmed people, but that's not necessary. We could also just focus on regular unharmed people and see if this plasmid DNA is integrated into the genomes of any of their stem cells. It leaves a calling card that is there. One of the reasons why I'm focusing on this is because it's kind of different from a lot of the other imagined harms where you can't really prove it. You can be suspicious because of the timing, but you can't really prove it. This one you can prove it because it leaves a calling card. Okay. You find it in the stem cells of harmed people, it's equivalent to finding a certain type of lead in someone who is now dead. It's reasonable to assume that that's what caused it. The royal we, meaning you guys, should insist that the FDA force Pfizer to get the DNA out of the booster and all future versions of this vaccine. I'm a real fan of this platform, okay? I think it has the potential to treat cancers. I really believe that this platform is revolutionary, and in your lifetime, there will be mRNA vaccines against antigens in your unique cancer, okay? But they gotta get this problem fixed. Okay? And right now, I think the financial incentives are too great to just keep on rolling with it. And it's gonna take some encouragement to get it out. The regulation that allowed this DNA to be there in the first place, I don't think that the amounts there actually exceed the regulation limits. In some batches it may. In the 2 batches that I looked at, one of them it was just under the limit and one it was just over the limit. My colleague in Boston has looked at a fair number of other batches, and there's a handful that are super high and there's a handful that are super low. But the fact that there is a regulatory threshold for amount of DNA allowed in a vaccine is a throwback to an era when we were talking about vaccines that were like a recombinant protein, or a dead virus, attenuated virus produced in CHO cells or something like that. And the DNA that might be in it is naked DNA. And you might have a little bit in the vaccine. That's not a problem, because naked DNA gets chewed up immediately upon vaccination, and there's no real mechanism for it to get inside the cells. They inappropriately applied that regulatory limit to this new kind of vaccine where everything is encapsulated in this lipid nanoparticle. It's basically packaged in a synthetic virus able to dump its contents into a cell. So I'm thinking Hanlon's razor here, okay? I don't think there was anything nefarious here. I think it was just kind of a dumb oversight. And it's gonna take, because the financial incentives are so great to just, sweep it under the rug, and the career incentives of people that approve this are gonna be, there's nothing wrong here, It's gonna take some encouragement to make people prove that it's okay. But I really believe this was an inappropriate application of an old school regulation to do a new kind of vaccine. And who knows, maybe we'll check a bunch of people and we'll find out for sure that this is indeed not a problem. And that will do the public good if we prove that.
Mr. Chair. Senator Cash.
Doctor, we appreciate all that you're saying, although we don't understand most of what you're saying.
I have a limited amount
I
of
hear
time.
someone down there agreeing a lot, so you must have been a chemistry major or something. But what is going to help us is to know what you can do, like checking a bunch of vaccinated people.
Of course, that's what I can do.
Right, but we are not going to have any authority of FDA to force Pfizer to do something. I mean, that's a federal issue. Unless you can explain to me how we could do something at a state level, some of this is going to have to be taken up by our congressman, right? So just whatever your remaining comments are, just keep in mind that what we can do, and really these technical things you're throwing at us, as the senator from Greenville has already mentioned, we're going to throw right back at you, because you're the expert. So if someone's going to do this testing, I don't know who we would find to do it, other than someone like you.
I can do it, lots of other people can do it. I've had a lot of coroners and pharmacists from different states contact me. I posted all this on Twitter, right? And so people will private message me and say, I'd like to send you some samples. And then they say, oops, state regulations will not allow our coroner to send any samples to this. So there are some policy issues that can allow this to happen or impede it. I don't know what they are, but I hear that there are mechanisms in place that will, you can encourage people to do things or not do things, but that's your wheelhouse, not mine. All I can tell you is what I found in the lab and the scientific implications of it, the policy implications of what to do with it. It's above my pay grade.
Thank you for coming today. I think I followed most of what you said. President Biden said the other day that there was a new COVID vaccine that this one really works.
There's no evidence to that as far as I can tell.
I understand that, and that's why I'm asking this question. Is there some way you could get a hold of one of those and do the same study that you did on these files to make sure that we're not using that DNA protein or whatever it is, the DNA, that we don't need them
that, and I will not get it unless I get a batch and find out that it's free of DNA, and then I'll take it myself. And I don't have any way of compelling that to happen.
So it was just basically a way to save money by doing it in such volume, that way, without them taking it back out later on.
I think nobody thought about it. I think it was reasonable to use the E. coli to blow up the plasmid to make the stuff, and then the pieces of the DNA are of a very uniform and small size. That's evidence that they took efforts to try to chop it up. And
Then they knew about it.
yeah, they knew it, and they took efforts to chop it up. They just didn't get it all out.
But having said that,
I guess that they just didn't think about the hazard for genome modification. Because it's not all that expensive to add another process to get it out.
well, that's what I'm saying.
I can't get inside my mind. I
This
don't.
was rushed too much, and that's what I'm saying. These subsequent, we've heard testimony, these subsequent, variant, subsequent boosters, et cetera, are leading to maybe not scientific yet, but at least collateral knowledge that apparently these things are causing death and disability later on, and also the aging process was heard about.
There's a lot of suspicious associations.
But it seems to me that before we can, in South Carolina, give this new vaccine a whirl around here, it seems to me that our people ought to be able to look at that, Mr. Chairman, see whether or not it's got this DNA, and if it does, fine, tell everybody it's got the DNA and the problems associated therewith. Then you got informed consent.
Correct.
Okay, but without that, we
No,
don't
it's
have
not
informed
informed
consent.
consent.
I'm not really happy about that, Mr. Chairman, and do what I can to try to help.
Knowing what I
Function
know,
otherwise.
knowing what I know now about this, I would still have recommended it to my elderly parents, but I probably would not have given it to my daughters. I feel like my consent was not as informed as it should have been.
Yeah, Representative Morgan.
I don't know where to start. I'm trying not to talk because it's a hearing and we want to hear you, but you have made so many questions come to my mind. And one I should know, but I don't remember, what percentage of vaccinated people have this kind of vaccination? Do you know off the top of your head? Like the majority of people that took the vaccine had this type, because weren't there multiple types of vaccination you could take?
The vast majority of people got either Pfizer or Moderna.
And we're talking about the
We're talking about Pfizer. My colleagues have looked at Moderna, and it's in Moderna too. In the few that we looked at, it's just not quite as high.
So you were here today, and you've come to present, and you noticed this. Where could you have gone if we didn't have this kind of ad hoc hearing?
Nowhere. Twitter.
So there's no way for you, even at your level of expertise, to say, hey, red flag.
I emailed the FDA and I tweeted at them. That's about the extent of my resources.
It's fascinating to me that in the state that we don't have some kind of, I guess it goes to kind of the entire thing that we're talking about, is that our state agency should have more focus on our citizens' health, and, great CDC consensus, but we'll make the decision. And there should be a way for, especially at your level, to get input to DHEC when you notice something like this immediately, and say, hey, DHEC, you should consider this, and then they can come and tell us immediately, hey, we need to get authorization, or you need to change this regulation to look into this, and it just seems like we totally dropped the ball in every direction with the state prioritizing, our decision-making on this kind of stuff, and investigating into it, just letting the federal government take it and do a terrible job.
So I had a lot of experience with DHEC rolling out the saliva test. Okay, so we invented the saliva test, and then we had to deal with DHEC to try to get it rolled out for the state. And it appeared to me that they were just overrun. They weren't prepared for what this pandemic was. There's no fault of theirs. I told people at the time that I felt like these were hobbits in the Shire that were, accustomed to taking care of small problems, and now all of a sudden we're in the War of the Ring, and there are orcs at the gate, and we're expecting them to deal with this tremendous challenge, and that's not who we put there, and that's not their fault. I mean, it's just we were not prepared to handle something of this magnitude. So some amount of grace, I think, is appropriate, even though we could do better next time by beefing up who's guarding the gates.
If you had tomorrow, fixes to the system, what would they be? That we could implement as a policy? But I mean, since you lived it and saw, based on the research, should we have somebody actually checking up, especially on something that is being pushed statewide? I mean, the state resources
You
are
have to
being
hire-
used saying to take this back.
You have to hire people that are qualified to tell the feds no. And that's not what we do here usually. In South Carolina, we hire people, sometimes we say to them no to the feds just to be ornery, because that's our culture in South Carolina. But many times, we say, well, I don't know, what do other people do? And we hire people all over that they ask, well, what does Clemson do? What does USC, well, what do they do over in this other state? Instead of putting people in place that we would have confidence in saying no to whatever the recommendations were, we put people in that we often encourage them to not make too many waves and just go ask the feds what they're doing. And that's not their fault, that's the culture that we cultivated. So I know that South Carolina culture is, no, we're gonna do our own thing. But in reality, in terms of actually doing stuff, almost always people will say, well, what do they do else in another state? What are they doing at the Fed level? And I'll just go along with it.
Would it be, and I'm not a medical professional by any stretch, would it be realistic for anything that is being promoted, especially on a large scale, vaccinations, coming from who knows where, to have it be investigated by people in our state, such as yourself, or is that,
It was reasonable to trust the FDA, even though I have my doubts about their independence now. Everybody just trusted the feds to do this, and at the time, that was kind of reasonable.
But going forward, I guess that's my question. Is it possible, is it reasonable for us to be able to have a system where we could, especially if the taxpayer money is being used to push it and tell people to get it, that we have it set up that it's automatically tested, basically, or looked into by scientists and medical professionals in our state to determine, maybe it's in DHEC, maybe DHEC has that, where they are required to look into it and have their own summary or decision on whether or not it's safe and effective, since we know that CDC and FDA and all these are not doing a good job of it. And I guess I'm asking you as a professional, do you hear that and think, wow, that's going to cost an insane amount of money and good luck? Or no, that's reasonable.
The actual scientific experiments are, I don't think, an insane amount of money. It's having the regulatory and financial independence to say, no, we're not gonna do it the way we're told until we find out that it's okay, when in reality, much of our support comes from federal sources. It's like if you have a better idea for how to build the interstate, you kind of have to do what the federal people tell you, regardless, right? Because that's where the money comes from for a lot of the interstate infrastructure. And I think, I'm not a policy expert, but I think that a lot of financial support through the healthcare system and elsewhere was tied to compliance to the federal narratives. And so I don't know that you can create true independence. You could maybe create some kind of oversight that would enhance the public trust in whether it was a good idea or not. But that's a different matter from us being able to go our own way all the time. That's your leader, that's your area of expertise, not mine.
But it is possible to have somebody look into vaccinations and do similarly to what you did.
I did this on my own money with free student. I mean, this is not terribly expensive to do these kinds of tests. But there has to be a system that professors are not going to be penalized for producing results that are counter to what the party line is supposed to be. And that you can create bubbles of where the protection for people whose job it is to check things, and if they come up with answers that nobody likes, they can still say them. And you have to create these kind of protection bubbles.
Yes.
Doctor, are you planning to publish these findings? Have you tried to publish these findings in the journal?
No and no. They're not. As of now, they are interesting and concerning, but they don't rise to the level of a peer-reviewed publication. The most likely, the best possible outcome would be that I would check a bunch of people, find out it never integrated, and this is not a problem, and then it will never be published, because papers don't publish negative results. Kind of the worst outcome is I could check a bunch of people and I find, oh, it integrated and it's causing these horrible things, and yeah, then I'll get a paper and be famous. But I'm hoping that that's not the way it goes. So you see how there, in academia for publication, there are all these perverse incentives in place, where the kind of thing you need to be done is the kind of thing that does not generate a publication. You need a regulatory body to check, find no problem, and tell the public, there's no problem, we checked, and there ain't nothing there. That will never get published, you know, or very seldom. It's hard to publish negative results like that. And that's why academic science is not the best place to do it.
How long would it take to do what it is you're talking about here, about check a bunch of vaccinated people? I mean, it's hard for me listening to all this for the first time to calculate how alarmed you are and whether, in your personal opinion, you would hit the pause button on allowing this new vaccine, so to speak, without knowing more. How long does it take, and how serious is it to find out this information before people keep taking these vaccines?
It takes about 3 hours to check a vial of vaccine to see if it's got this in it. About $100 of reagents. And I'm not gonna get it unless I find a vial that I can check ahead of time and make sure it's not there. And if it is there, I'll take a pass on it.
Dr. Bookman, thank you so much for being here. And I would like to say that I was sort of in the world of COVID that we've been dealing with all the lies, and cover-ups, and misinformation out there. I would almost call you a whistleblower. And Dr. Lead, I think we may have found our state Surgeon General here today.
Thank you for your confidence.
But what I would like to say is, as we wrap it up, is I do appreciate you. I understand where you are employed. And you and I have had a little conversation about how wonderful tenure is and things like that. But if you experience any retribution or any harassment for coming forward at this hearing and testifying, would you please let us know? Because I can assure you, you will have an army behind you with whatever may come your way.
Thank you very much.
Brett Morgan has one more question. We've got to move on. Dr. Jancy is, I think, under a time constraint.
I should have asked this. So you didn't, you haven't interacted with DHEC about this?
No.
Okay. I was just wondering if you had any.
I interacted with a couple of people at the FDA. I just sent them emails and said, hey, you should look at this.
Thank you so much. Next is Dr. Jancy Lindsay. I hope you can.
I hope you realize what a hero this man is. I've spoken with many scientists about checking for this months and months and months ago. None of them would do it. I spoke to the U.S. Senate in December of 2022 about the risk of this being passed to our children because of it being reverse transcribed simply from the RNA before we knew that there was DNA in the shots. As soon as I found out there was DNA in the shots, I went all over every social media platform I could get to and started ringing the alarm bell. Several other scientists got exactly, you don't have to say that. At this point, I have little time, so I'm going to follow up to what he said. Well, just show the one slide, the one bare slide. So I disagree with Dr. Von Carlson that I think that this is the most dangerous platform that has ever been released on mankind. That is very easy to see in the VAERS database where you have more deaths in just a couple months after the rollout than you have in the past 30 years for all the other vaccines combined. You would have to shrink that and go up. So there you go. So these are all the other vaccines for the past 30 years combined, and this is
what happened, sorry, and this is what happened during COVID to deaths from vaccines. And you see, we're at over 35,000 deaths. Typically, you would get no more than 200 deaths in a year for all 30 vaccines, or for all of the vaccines combined. This is the past 30 years of deaths from vaccines reported into the VAERS database. You've already heard earlier that this represents only 1 to 13% of the cases that are normally reported. This is a safety signal. This is a safety signal. This is the platform itself, okay? In the clinical trials, we saw deaths. We definitely had deaths. That was using process 1 without the contamination, okay? What may not have been clear is that the shots tested on the people in the clinical trials were vastly different than the shots tested or given to people released on the population. I'm short on time, so I'm trying to get this in. Basically, people were given in the clinical trial a clean shot. Everybody else was given these contaminated shots. Every single vial that's been tested by every scientist around the world is contaminated with these plasmids. And some are contaminated. When Kevin McKernan first tested the vials, he found that one of the vials contained up to about 3% of the nucleic acid material was in fact DNA. So this is not some residual contamination that's carrying over. This is significant contamination. Why does that matter? Gene therapy was never brought to market, even though it's been over 40 years in development, because in the past it caused latent cancers that developed 2 to 4 years after these were given, because it caused lethal autoimmune reactions, even when you were producing human proteins, not viral proteins, not bacterial proteins that you are displaying on the surface of your cells. Think about the logic of this. In traditional gene therapies, and these are gene therapies, they would be classified as gene therapies. In traditional gene therapies, you sent in a genetic message to make a missing protein. That protein is identical to the protein that should have been in your body, but you're missing. This time we're sending in a sequence and asking it to make a piece of a viral protein, and we're displaying it on our cells, and then our body is attacking it and killing those cells. It doesn't stay in your arm. They said it would stay in your arm. It goes to every single cell in your body, every tissue in your body. It goes to your brain. It goes to your bone marrow, where then your body is able to attack these cells. It is not a healthy platform for this. There's a difference between using this technology for cancer or for fixing inborn errors in metabolism as compared to using it in a vaccine. There you understand the risk. Here the risks were not told to people. With this DNA being present, what Philip did not touch on is that there are sequences within these plasmids. I personally feel that this is an intentional, I believe that there is nefarious intent. And I'm going to tell you why, and it's something that he didn't touch on. There are SV40 sequences, excuse me, there are SV40 sequences within the plasmids that were not disclosed to the regulators. The SV40 sequences, if you recall, the SV40 virus was a contaminant of the polio vaccines. It is thought that that contamination of the virus, which is oncogenic, caused many of the cancers for the next several decades from the people that received these vaccines. Now the whole SV40 virus is not in the shots, but what is in the shots is a special sequence. It's called a nuclear localization sequence, which is in the shots to take the plasmid DNA directly to the nucleus of human cells. It is not needed to grow these in bacteria. You would not have to use this to grow it in bacteria for the purpose that they said it was for, to make lots of copies. This sequence takes the DNA to the nucleus of human cells, where it can then be integrated, or where, as Philip said, it is most likely to be integrated. So all this about there's no DNA in the shots, they will not go to the nucleus, they will not integrate with your DNA is not true, and they knew it from the beginning because they knew the plasmids were there. That's a problem. There's also an SV40 promoter only designed to be expressed in human cells, not bacteria cells. Now, Philip has checked in something he didn't say, which is good news for people. Dr. Buchholz, I keep saying Philip, which is good news for people, is that most of the sequences were broken. Have they been intact? And if there are any that are intact, and this is something he should have said, we have to check. They can infect the E. coli in your gut. That's what they're designed to do, to infect the to infect E. coli, which means you can be a perpetual spike factory because they're self-replicating, and they would self-replicate in the bacteria of your gut and then make spike over and over and over again. That's a problem. They also carry an antibiotic-resistant gene cassette to kanamycin and neomycin. Kanamycin is the main antibiotic used to treat tuberculosis. Neomycin is another antibiotic that's widely used. People that receive these, if it transfects the E. coli in your gut, it can make your gut and other bacteria, not just that, it can make them resistant to those antibiotics. That is a huge, huge risk. And it's something that's known for plasmids. It's something that they're careful to make sure that you don't have these antibiotic resistance genes if they're making something that should go into gene therapy. And now it's here, now it's present. I've worked for several months to try to get these shots recalled, completely recalled. They're dangerous. Excuse me, I need to get a drink of water, but they're dangerous. We're injecting these in our kids. We don't inject contaminated medical products in our kids. Something Dr. Buchholz didn't touch on as well is if there's that much plasmid in the shots, there's a very good chance that there's bacterial endotoxin in the shots, which means bacterial proteins which can cause anaphylaxis and even death. And that may be what caused some of the rapid deaths that occurred right after people got these shots. There's so much more to touch on. We've seen massive cases of miscarriage and stillbirth. Normally, during years, we wouldn't see more than 25 cases of miscarriage or stillbirth for all the vaccines combined. In 2021, we saw 3,428 cases of stillbirth and miscarriage reported into the VAERS system. Remember, no more than 25 typically in a year is normal for all the vaccines combined. 3,428 in 221. In 222, we saw 1,525 stillbirth and miscarriage. And halfway through that year, the FDA, or the CDC said they would stop reporting on, they would stop making all their information public because they did not want to encourage vaccine hesitancy or misinformation or misinterpretation of the data. So all of a sudden we saw what was going like this go like this in February. That's artificial. We can't even trust the data coming out of the CDC anymore. The FDA knows about this contamination. They're not doing anything. I'm sorry this is so rushed. I just wanted to address what Dr. Buchholz was not able to. He and I have the same degrees. I have a degree in biochemistry and molecular biology, and I'm a toxicologist and an expert witness as a profession, nationally and internationally. This is outrageous. I've never seen anything like this in my entire career. We have got to pull these shots and restrict them from our children. We cannot inject these into babies and children. These are contaminated, dangerous, lethal products. I don't agree with Dr. Buchholz, but I believe that he's just seeing a lot of this data. I feel like he is where we were 3 years ago. So that's basically, if I don't leave now, I won't catch my plane. May not catch it anyway.
You had said earlier nefarious. You felt like this was more nefarious than Dr. Buchholz. In what sense are you saying?
The SV40 sequences, they should not be there. They don't need to be there to grow this into grow this in bacteria. I don't think it's an accident. They could have chosen another plasmid that did not have the SV40 sequences. If these sequences sit above an oncogene and they're promiscuous, that means they are likely to integrate into places more likely than other genetic inserts. Thank you so much. Then they can cause cancer. Insertional mutagenesis anyway causes cancer. And that's the risk. That's why gene therapies were not brought to market for so many years, because there was a risk of causing cancer from insertional mutagenesis. We never needed these vaccines. We had treatments that worked. One of our doctors here is going to tell you about that. Hydroxychloroquine and ivermectin, I can tell you as a toxicologist, they are not toxic. They're some of the safest drugs you can use. There's no reason, once the FDA found out about this contamination, okay, and we looked to see endotoxin levels, but they've got them all redacted. Why would you redact them if you were trying to be transparent? Why would you hold the data for 75 years, all of the clinical data, for 75 years from these if you were trying to be transparent? Tell me why. There is something very unusual going on here that is being done differently than it's ever been done before. We don't give experimental products to pregnant women. We don't give experimental products to babies that have a death profile like this. It's not done. It's never been done before. Please protect your citizens. Please. I am begging you to protect your citizens. We've got to get one state to stand up and do the right thing. Do whatever you can so that other states will follow.
Thank you, Dr. Lindsay. Any questions?
Again, sorry, I was a little urgent in that.
No, you
I
were fine.
rescheduled my Uber twice, so.
It's just very difficult to keep this thing on schedule with him, but thank you for staying so much. Thank you for staying, and thank you for presenting, and we appreciate it so much.
Yeah, and if you have any questions, please feel free to come.
We will be reaching out, I promise. Gene, who's next?
Mr. Chairman, we passed over to meet the time obligations. We passed over Mr. Recknagel, so it's probably time to call him up now.
Drew Recknagel.
Beg your pardon, sir, did I mispronounce your name?
That's perfectly acceptable. Thank you. And thank you all for allowing me this opportunity to share some ideas. I intend to go no more than 15 minutes. In fact, maybe I can slam through a little bit faster.
Sure. Andrew, hang on one second. I think we maybe, did you have a presentation? Okay.
It does, and it's, when I'm opening it, it is installing an update automatically.
Oh.
It's gonna take time.
That's our luck, isn't it?
I apologize for yeah.
That's true.
It's an auto Adobe thing.
Andrew,
Here we are.
Andrew, if you could give us a brief, a little bit of history about yourself and what, what you've done in your career and what brought you here.
Yes, I am a research scientist. I spent most of my career in academia at universities and private research institutions. My expertise is biology in general, but lots of specialties, including genetics, development. I was involved in cardio research and cancer biology, and a lot of neuroscience in particular. What I'd like to do is provide some broad ideas that hopefully will help the whole picture that we've been discussing. I'll help piece it together and how we got to this place. And after I get through some of that, I would like to make some specific points, point out some specific things of relevance, and So to start out here, this is one of the most important papers that I know of, published in 2005 by John Ioannidis. He's actually published a considerable amount of work over his career and continues to at this point. And this piece of work right here, this paper is one of the most cited publications on record, I think, in the science world. It is for sure for him, and I think in general that is also the case. And this is a general, very profound perspective. As you can see in this highlighted green portion, it can be proven that most claimed research findings are false. He means this in a mathematical sense, and mathematically proven. And he does this with statistical arguments and demonstrations, and I won't get into that because that's a whole statistics class, technically, to get into. However, I'll go through some of the descriptions for how this comes to be. And I'll make some side comments about these. One more comment about Ioannidis. He's done these meta-analyses, and he now has a large research team that their specialty is meta-analyses. And they've continued to look at many different types of medical, biological fields, and they find these consistent trends. One noteworthy point is in the field of nutrition. There are practically, for every nutrient or every food product that exists, practically speaking, there are studies that say they do and they don't cause cancer. So that's just a prime example that many of us can be familiar with, especially studies about eggs and newspaper reports. Every time you see a study about eggs, it's saying something completely different than the previous one. So one point is that the smaller the studies, the less likely the research findings are to be true. And that really comes down to sample size, the amount of research subjects. And so you could think of 143 infants studied for 5 days. That's a small study. How about 8 mice? That would be a very small study, and that's relevant kind of recently. Smaller the effect sizes of a scientific study, the less likely the research findings are to be true. There's a lot of interesting findings or interesting factors that just have small effects in outcome. And I'll just keep moving on. The greater number and the lesser the selection of tested relationships in a scientific field, the less likely the research findings are to be true. This relates to multiple testing, and if you are not rigorous and careful about the way you run experiments, you end up obliterating the statistical relevance that is utilized as a demonstration of the reality. If we were to suggest that the regular thresholds that are utilized would produce a spurious or inaccurate positive result 1 in 20 times. One of the common methods is this threshold, where we would expect when the positive result is claimed that there's a 1 in 20 chance that it's incorrect and there's actually no relationship between the experimental group and the null hypothesis. Well, if you go and ask 20 questions, then you're far more likely to get a positive appearing result without it actually being meaningful. It's only by chance. The greater the flexibility in designs, definitions, outcomes, and analytical modes in the scientific field, the less likely the research findings are to be true. The greater the flexibility in designs, definitions, well, definitions have been changed at a rapidly increasing rate, which is a huge problem underlying everything that we're talking about. Flexibility in designs, like the clinical trials in which they change the format as they go, like they go and inject the control group with the experimental substance when only a few months have passed, preventing the control group from ever showing long-term difference. because now they're all the experimental group. That is a perfect example of flexible. It's not really flexibility in research design, it's really it's worse than that. It's abusing research designs, and unfortunately, these are not uncommon. One of the explanations, just in the academic research lab, a student or a group spends a considerable amount of time on a certain project, and they're analyzing the data as they go, and they're starting to see, oh, they're not getting the results that they were interested in. Well, the typical attitude, the typical response is to try and salvage the work that they did by looking for other outcomes that weren't necessarily stated in advance, and that, if not done carefully and honestly, ends up in a bastardization in the outcome. The greater the financial and other interests and prejudices in a scientific field, the less likely the research findings are to be true. That's highly relevant. The hotter the scientific field, with more scientific teams involved competing, the less likely the research findings are to be true. This is partly because of the multiple testing idea that I alluded to before. If 20 groups are using careful methods and they use the same kind of analysis that would allow a 1 in 20 by chance apparent outcome, if there's 20 groups that are doing the same question and all in good faith, there's a likelihood that one of them is going to apparently find a positive relationship when it actually doesn't exist. They'll go ahead and publish it, they'll get credit for it, and the other 19 teams that had attempted the same type of work and found no results, no effect, they're usually not likely to publish. That's one of the problems in the prevailing problems, is that there's a lot of findings that have potential value, but no one ever hears about it because it's not noteworthy enough to be accepted into a research journal. So there's a couple more points about this analysis, why most published research findings are false. Most research findings are false for most research designs and for most fields. And this is really interesting. Claimed research findings may often be simply accurate measures of the prevailing bias. And that makes a lot of sense to me. I've seen it happen repeatedly. How can we improve the situation? Well, he gives some ideas, but I'm not going to share them because this was published almost 20 years ago, and none of the improvements have taken place. As far as I'm aware, everything's gotten worse. And this is my direct experience. This is pertaining to the students in the colleges, universities, through the graduate students and the postdocs, and the professionals with further degrees. There's a considerable amount of neglect in proper behavior and considerations, and everyone's got excuses as to why. So I'm going to read this brief description from Richard Feynman, who's a famous physicist, Nobel laureate. He gave a commencement address at Caltech in 1974. And I find this highly relevant and helpful to understand what can and too often does go wrong in research science, professional scientists. So he went and explained that in the South Seas, there's a cargo cult of people. During the war, he means World War II, they saw airplanes land with lots of good materials. And they want the same thing to happen now. So they've arranged to make things like a runway, put fires out alongside the runways, to make wooden hut for a man to sit in with 2 wooden pieces on his head, like headphones, and bars of bamboo sticking out like antennas. He's the controller. And they wait for the airplanes to land. They're doing everything right. The form is perfect. It looks exactly the way it had looked before, but it doesn't work. No airplanes land. So I call these things cargo cult science, because they follow all the apparent precepts and forms of scientific investigation, but they're missing some essential, because the planes don't land. Cargo cult science, I've seen the majority of my experience, the people that I've worked around qualify for this. And they would be terribly insulted if I
single them out, and I won't because I don't need to. I am saying that it's like the first paper. It's unfortunately a majority. And there's lesser and stronger degrees of this, and there's a lot of excuses, there's a lot of explanations as to why, but in our age of high technology and distraction across a variety of dimensions, people are all too often imitating, pretending to do science, thinking that they're doing science to a large degree, but not actually following the methods carefully and with humility and with honesty. Those are two features, two characters that I found sorely lacking in the research world. There's careers to compete for and publications and grant money. These are some of the explanations as to why the situation is taking place. In the interest of time, I think I'm going to skip pretty quickly. What I found is fake it till you make it. It's a very common saying, but it's including in the research world. It's probably only increasing, and people are uncomfortable about the fact that that there's too much to know, that they don't understand enough about what their expertise is supposed to be in. I've actually found that research heads of research laboratories have, in my presence, recommended to their students that they read the book, The Imposter Syndrome, and utilize it as help, as self-help for the situation they find themselves in, which I was horrified to hear. Rather than the mentor, or the supposed mentor, actually giving leadership and instilling wisdom, they were giving the students an excuse as to why they are feeling the way they are, feeling as they really ought to, because it's an honest feeling, realizing that there's a problem and that you're not in control of the basics, frankly. And I would like to get into this, but I'm going to skip past it. What I'm referring to is the philosophy of science, empirical falsification. And all too often, we're operating under the old style of positivism, which is logical, it's reasonable. It's the way we talk. It's embedded in our language, I think. But falsification is a very difficult thing to do and operate on a regular basis. So that's the title of the first paper that I wanted to bring here to make the point that even though it's a peer-reviewed study, even though it's potentially a meta-analysis, that doesn't mean that the conclusions are certain. In fact, they can never be certain. So it's a red flag if anyone who's a scientist or otherwise makes the strong claim that we know this for sure, this is proven to be true, don't believe it. It is a matter of belief, and it's totally inappropriate to believe anything scientifically speaking. Belief is an issue. On that note, I find myself agreeing strongly with most of what the previous two speakers said, and some small disagreements, or some meaningful disagreements that I personally have. And that's just the way it goes. None of us are necessarily right, and I can't say which one of us is right, even when I would want to argue my perspective, right? So, a couple of interesting things. In 2020, after a while had passed, I decided to do a couple of very simple word searches. And right away, what I found, with only a few keywords, was this paper, published in 2015, Nature Medicine. And the title is "A SARS-like cluster of circulating bat coronaviruses shows potential for human emergence." All right, I'm going to paraphrase the abstract. Here, we examine the potential, the disease potential of SARS-like coronavirus, which is currently circulating in Chinese horseshoe bat populations. Using the SARS-CoV reverse genetics system, we generated and characterized a chimeric virus expressing the spike of the bat coronavirus in a mouse-adapted SARS-CoV backbone. The results indicated that, okay, I'm going to skip a little bit further. Wild-type backbone can efficiently use multiple orthologs of the SARS receptor, human angiotensin converting enzyme 2, that's the ACE2 receptor. It can utilize that when they give it that ability. It can replicate efficiently in primary human airway cells and achieve in vitro titers, equivalent to epidemic strains of SARS-CoV. Additionally, in vivo experiments, demonstrate replication of the chimeric virus in mouse lung with notable pathogenesis. All right, this is gain-of-function research. This is meddling with manipulating collected viruses and making them infectious for other cells or other animals that those viruses weren't initially capable of infecting. And this research took place at Chapel Hill, North Carolina. And more so, there's a couple of authors, when you look at the affiliations, Zhiying Ji and Zhengling Li Shi, they are both associated with the Laboratory of Special Pathogenesis and Biosafety, Wuhan Institute of Virology. So Ralph Barrick at Chapel Hill trained these two, who then went on to do the work at the Wuhan lab that is now finally becoming more accepted, was supposedly the origin of the most recent coronavirus. And it's curious that I believe that Ralph Barrick is still at Chapel Hill. I believe he still has a research lab, still getting grant money, and it's curious that I don't think much attention has been given to this connection. So there she is, Zhengling Shi, who's known as the Wuhan Batwoman. She was trained in North Carolina a decade ago. And this is quite interesting because that publication has an update, March 2020, editor's note. We are aware that this article is being used as the basis for unverified theories that the novel coronavirus causing COVID-19 was engineered. There is no basis for this. There's no basis that this is true. Scientists believe that an animal is the most likely source of the coronavirus. So, okay, maybe take their word for it. I refuse to call these things vaccines that we've been discussing today. I prefer to call them experimental injections, or more accurately, experimental injections that force prolonged transgenic expression of a newly engineered cytotoxic protein. Okay, so just a couple more points. I found this very interesting. This is published in 2021 in the Proceedings of the National Academy of Sciences. This is not a research paper, it's more like an editorial from Dr. Peterson here. He is an expert in all the molecular biology, genetics, and relevant stuff. So the abstract is a chance conversation with a non-scientist about the mRNA COVID vaccines. Conveyed here reminded the author of our enduring responsibility to accurately portray science to the public. So a couple quotes from his relatively short letter. This struck me as a perfect storm of an uneducated, reasonably informed non-scientist being led astray by how the media often doesn't quite get it right, though we all recognize that too much detail can be a narcoleptic. On a side note, I wouldn't say the media often doesn't quite get it right, but especially in this case, often gets it entirely wrong. And you're better off believing the opposite of what they claim. I told my friend that the doping was, and so he's talking about the modified RNA, and Dwayne Lee earlier mentioned the pseudo-uridine component of the messenger RNA. So I told my friend that the doping was, using layman's terms, he listened thoughtfully, and then I came in with my final shot. Nature is full of RNA that is, quote, doped, and even DNA is as well. These chemical modifications are not done by mad scientists, but are the very biological systems in which these RNAs and DNAs reside, using their own enzymes. He left somewhat convinced and hopefully is now vaccinated. And then I, by chance, happened to click his name and discovered a competing interest statement admitting that this guy owned Moderna stock at the time. And what this piece, in my interpretation, is this piece in PNAS was a guide to scientists as to how to convince your friends and your family. Because they all know better, they all know what's right, and it was a set of strategies that you ought to use to convince people to go ahead and be obedient. A couple of review articles, a couple slides each. Modifications in an emergency, the role of N1 methyl pseudouridine in the COVID-19 vaccines. It's not just pseudouridine, it's N1 methyl pseudouridine, which is another alteration. And right from this paper, the chemical components of messenger RNA vaccines are pleasantly unremarkable. The non-natural RNA nucleobase N1 methyl pseudouridine. Well, the previous guy just claimed that, oh, these are normal. They happen all the time. That's not true. That was a lie. He should know better. In fact, this N1 methyl pseudouridine is a relatively new modification that's only been studied for a few years, and there's a lot to be, remains to be understood about it. It's important to gently push back on the narrative that this process was hurried, which may invite skepticism. Well, we wouldn't want to invite skepticism? No, of course we should. Skepticism is supposed to be the way the scientific enterprise works. Here's a quick example without all of the details. Uridine is presented here, pseudouridine here. This connection is different. The N, the nitrogen, ends up here. And the connection down here is through the carbon, not the nitrogen. The N1 methyl pseudouridine has an additional methyl group off of that nitrogen. Okay, so that's just a graphical example of what we've been talking about. N1 methyl pseudouridine. They never, it was never accurate to call them messenger RNA vaccines. I don't want to call them vaccines anyways. I would technically call them N1 methyl pseudouridine mRNA experimental injections, or lipid nanoparticle contained experimental injections. And moving forward, those are ideas to keep in mind. And because I can, I'm going to show a quick example of some work that I'm very fond of. I did a number of years ago. This is part of a mouse brain. I bred this mouse with a few different transgenes. I put them together in this mouse. And I collected the brain and prepared it and did the imaging. And so what this represents is acetylcholine nuclei that project out into cranial nerves, and a number of the main cranial nerves are represented in this image. I show this as a counter to another image right here. These two brain images are in the same general orientation. However, this one, the fluorescent protein was triggered by a viral vector injection. We put this animal in a stereotactic apparatus. It was under anesthesia. We drilled a small hole in its skull. We lowered a very fine needle down very, very slowly and injected a tiny, tiny amount of engineered viral vector into this location that I'm pointing at. However, the majority and the most obvious results were not the ones that we intended. It was the needle track. You can actually see it's lit up. You can see a bunch of bright spots up here in the meninges where the needle penetrated and went through. And the third ventricle here, the brightest thing in this image, the biggest thing in this image, is the membranes of the third ventricle. And it's all contaminated with the injection that we intended for the mid-lower brain area down here. And I present this as an example of how injections don't necessarily go where you intend for them to go, and you should never expect them to only stay in the place that is intended. One more slide. This is very curious, something that I came across recently. This is a 2019 publication, and this is in Nature Communications. And here we see a proposed method for how messenger RNAs contained in lipid nanoparticles may end up escaping from the target cell and moving out
out into circulation. That's what the implication of this image, this diagram is. I find it quite useful and quite curious because I speculated, hypothesized the same thing recently, and then we discovered that it exists in the literature already, which makes sense to me. The whole notion that not only safe and effective, but it's going to stay right where it was injected, was preposterous. It's either naive or it's maliciously neglectful, and that's it.
Any questions for Ms. Raynold, thank you so much for coming. I think it speaks volumes that you've dedicated your life to science, and that prior to this tenure in your life, you were working for a very prestigious research institute in Virginia. Became so disillusioned with the lack of true science that you basically walked away. And I think that speaks volumes about what we're up against, trying to combat COVID and other things that may come our way. It's something we need to bear in mind. So thank you so much for presenting.
Thank you for your time.
Mr. Chairman, we are very data heavy today, and so we've been receiving information right up to the present that our presenters need. And so we need to take a very quick tech break while all our LSA.
If Mr. Brilliant says we need